to move things out of the way so they're not in your line of sight. So today, and the plan kind of tentatively throughout the semester, I'm not going to stand here and talk for 4 hours straight because that's not fair to anybody. We'll do roughly about 2 hours. I'll give you guys 15, 20-minute break to grab food, grab a drink, go to the bathroom, whatever you might need to do, and then we'll reconvene and hit the ground running on the last hour and 40 minutes. We're going to need it in order to be able to cover all the material, and my hope is as the weeks go by and I kind of gauge a little bit better how fast we're able to move through the material, it will help to know whether or not I can add other activities and things in so that, again, it's not just me standing here for 4 hours. Ideally, we'll kind of incorporate some case studies and some troubleshooting, some questions, things like that to get you guys a little bit more involved in actually applying the information that we're talking about that day to scenarios so that maybe it'll help stick the information. So that being said, I'll start with attendance and have you guys kind of raise your hand, shout, hey, whatever you want, something to let me know who you are. Georgia. Here. Felicia. Chardonnay. Here. Kate. Zandra. Did I pronounce that right? Okay. Michaela. Mercedes. Jessica. Heather. Isaiah. Howie, I've got him on distance. Sam. Okay. You go by Sam or Samantha? Okay. Gabrielle? And Sam, you're distance also, right? You're one of mine? Okay. I'm just marking it so that I've got a chip in my brain. Michelle. Hillary. And Rebecca. Okay. And Sam, you're from Shoto? Big Sandy. Howie's Shoto. Okay. Big Sandy. Conrad. You're a ways away. What are you doing here today? Felt like you were up for a drive?
I really wanted to come for the State Board of Nursing came down to talk about the NCLEX, so I really wanted to have that.
Gotcha. Okay. So I actually drive in from about halfway between here and Helena every day, or when I'm teaching. I do try to have my office hours when I'm here on Thursdays. Typically I do them from 11 to 1, basically right before class, so I'm here. That being said, my life is kind of all over the place. I work registry at benefits, I work part-time at Community Medical Center out in Missoula, and then I'm here teaching with an 18-month-old and a husband who doesn't work 9 to 5, and he's away from home. So I'm kind of like this when it comes to my schedule, and oftentimes if you guys email me, it'll be at 2 in the morning, so you'll get a response because I tend to work night shift. So email is going to be your best form of communication. I say 24 to 48 hours is about the time I ask for you guys to be patient on a response, just because I can't promise you that at 9 a.m. every day I will be checking it. It's usually much quicker than that. I would say it's usually within 12 hours of the email that I get back to you guys. I am more than amenable to coming in on other days to meet with you guys if there's a big issue. I am happy to talk on the phone. It just sort of depends on the situation and how imminently you need me. As the semester progresses, there's going to be projects, there's going to be other assignments, and if you have questions, again, email is going to be your greatest resource. But if that's not explaining things well enough, don't hesitate. I mean, I want you guys to succeed. I want you to have me available to you, and I know only having that limited 2-hour window on 1 day a week gets to be really hard. You guys are my only priority this semester. I don't have another class, so I'm yours. Use me. So this week we're going to talk about course expectations, which we've talked a little bit about, your responsibilities, how you are going to be graded, which is probably on the top of your priority list as far as all of the things we're going to talk about. And then we're going to dive right into maternal child nursing. We're going to talk about the reproductive system, the menstrual cycle, which can get to be really complicated, even though most of you guys have experienced this for a good portion of your life. You would be amazed at how many people have no clue what's actually going on inside. I can guarantee you, if history serves itself, you need to study that when it comes to the exam. Don't just assume because you've had it, it's easy. The guys in the class tend to outperform the girls on any kind of menstrual cycle questions that I've ever given because they study it. Common reproductive concerns, we'll talk a little bit about risk factors, STDs, contraception, all stuff that I would hope at some point in your lives you guys have been exposed to education about, but we're going to go, again, into more depth. Talking about changes in the female reproductive system across the lifespan. We'll kind of touch upon menopause, some disorders of the female reproductive tract, cancers, and then we'll switch gears and really go into more like the maternal aspect of things, and we'll talk about fetal development, genetics, and the very beginnings of pregnancy. It's a lot of material, if you can imagine. Slow me down if I'm talking too fast. I have a tendency to speed up when I get excited about things. I'm originally from the East Coast, and that tends to get away with me when I'm excited. So don't hesitate to ask me to slow down by any means. So, your responsibilities for class. Attendance expectations. Class participation is a must. There's not necessarily a grade that goes along with it, but again, nobody wants to hear me for 4 hours. Excused versus unexcused absences. An excused absence is one where you've basically notified me 24 hours in advance. It looks much better if you can just let me know that you're not going to be here. Again, I'm not penalizing points based off of it, but it's a personal accountability kind of a thing. And then tardiness. It's, by school definition, it's anything later past 5 minutes or leaving class before the 5-minute mark at the end. Again, it's not something I'm taking points off for, but just common courtesy. Syllabus changes. I'm going to try really hard not to change the syllabus too much on you. I worked pretty hard on getting it pretty ironed out. There's a course calendar on there that we're going to hold to for the most part, but a lot of it's just going to depend on how quickly we move through things. I can tell you right now the exam dates will not change. Those are pretty ironed out. I'm going to shoot an email to the gal that I need to be able to reserve computers for you guys for the exams. They'll be taken ideally in this classroom. Everything is done through that D2L site. So again, I don't anticipate any syllabus changes, but if something comes up, I will put a news announcement on D2L so that you guys are alerted that something changed, and it's not just like, oh, surprise, surprise, at the end of the semester, grades have changed or whatever. Disruptive behavior, please. I understand probably better than anybody that life goes on outside of these 4 walls. If you need to have your cell phone on you, that's fine. Just put it to silent or vibrate. That's how I have mine on in case somebody needs to reach me about my daughter. So I completely understand that if you need to step out to be able to answer a phone call, that's fine. Just try to be respectful of your other classmates because they're going to want to not be disrupted either. So if you need to get up and use the bathroom, use the bathroom. You don't need to ask. Just try to be reasonable and responsible about it. Again, I talked about that classroom break and then makeup exams. Per program policy, if something were to arise and you were going to be absent on the day of an exam, ideally, I need to be notified 24 hours in advance. It has to be something acceptable. A doctor's appointment does not count. You can reschedule those. It's things like you have a wedding that you're in out of town. You had a family friend die. You've got a funeral to go to. You've got a military obligation, whatever it may be. It's got to be something that is out of your control that you cannot reschedule. We can change the date of that exam for you on one instance during the semester. That's the only chance you get. So obviously it's not something that we hold lightly. I don't feel like historically we've had to do that too often, but we are an accommodating institution as far as that kind of stuff goes. So if something comes up, if your kid ends up hospitalized or your husband's having surgery and he needs somebody to drive him home, you know, things like that, just approach me. You know, I'm pretty understanding about that kind of stuff. So it's just got to be in advance. It can't be, it's not that you can miss the exam and then come talk to me. Again, unless it's some kind of a extenuating circumstance that you can't avoid. You know, if you're in the ambulance taking your kid to the hospital, you don't need to make me your priority to let me know that you're not going to be here. You know, there's other things that are slightly more important. So that's kind of the makeup exam situation. As far as grading goes, there's a couple of different things that go into your overall grade. You are going to have 2 quarterly exams, a midterm, and a final. Those are your big components of your grade. Each of the quarterly exams, so you'll have one that covers OB stuff and one that covers pediatric stuff. The midterm will cover all of the OB content, and the final exam will cover all of the pediatric content. So you'll basically have 2 cumulative exams within the semester, and then the quarterlies are each individual of the content we had covered just prior. So the quarterlies obviously weigh a little less. They're 50 points each. They're 50 questions each. Pretty straightforward. Your final and your midterm are both 100 points each. They're 100 questions each. Your quarterly exams are an hour long. Your midterm and final are 2 hours long. Pretty straightforward, pretty easy. We will have class afterwards because we can't afford to lose out on that time. ATI journals, they're going to be graded exactly the same way as they were in Mrs. Hastings' class last semester. The rubric's already built into your class and on D2L. The expectation being that you're only here for 10 weeks, you're not going to get through all of the material. So the expectation is for each of the ATI journal checks, you'll be expected to have 10 questions done. The dates that those ATI journals are due are in your course calendar, in your course syllabus.
On Sunday night?
I'm actually having them do the day of class. So by 1 p.m., the day of class is when you have to submit them till.
Is that just going to be a Dropbox and just drop?
Yep. Yep. Everything, for the most part, there'll be one slight exception, which we'll get to here in just a second. Everything else is on D2L. Your clinical paperwork, your reflection papers, anything that's going to get turned into me, D2L. Because I'm only here on campus 1 day a week, it makes it really hard, and I don't want you guys to submit something after I've walked out the door and then get marked late because I don't get it until the next week. So everything is done online, whether you guys are distance or not. So the ATI journal checks, there are a few of them. There's 3 through the semester, so they're 10 points each. The next one is due next week. We hit the ground running because I'm trying to space things out so that you're not getting nailed with a project, ATI journals, and an exam all in 1 week, because that would just be a little mean. So I'm trying to space them out, but unfortunately the only one that I could kind of shift around and figure that you guys don't need as much time for was the ATI journal, so that's why it's due next week. Plus, getting used to NCLEX style questions is going to help you. All of your exams, all of them, are NCLEX based for here. There will be select all that apply questions. I try to make them only about 5 to 10% of the exam grade so that it doesn't totally annihilate you guys, because nobody does well on select all that apply questions, but you have to get used to them because they will surface on your board. So those are your ATI journals. I think it's every 3 weeks that they're due after this one, but just rely on that course calendar, and there will be a Dropbox submission underneath the weekly tab in your course content on D2L for when they're due. Maternity case study. I haven't posted this one yet, but I will try to get it up this week so that those of you guys that are eager beavers can get working on it should you choose to. I haven't built a rubric yet for it, but we will talk about it here in just a little bit. It's worth 25 points. Your health promotion project won't be due till close to the end of the semester. It's a pediatric-based project, and again, I'll talk about that here in just a little bit. And then these weekly online quizzes. You will have a weekly online quiz that will open up about an hour after we finish class, because it gives me time to review the questions and make sure that we actually cover the content that the questions are based on. So it opens about an hour after class, and you have until the following class, basically, to answer them. I have to look. I can't remember. I think they close the midnight of Wednesday. Yeah, the Wednesday to the Thursday is at midnight. I haven't quite decided yet, and we'll see how things go today and next week on whether or not you guys want me to open those up for you, because what I do typically is the quiz is submitted, you guys take it, you get your grade, but you don't get any feedback on the questions, and then we go over them in class the following week. Kind of gotten mixed feedback on that. Some people don't like having to wait that long to figure out what they got wrong, because then they feel like they internalized the wrong answer, not knowing which one it was. So we'll see how you guys feel at the end of next week, and we'll talk about it after. Does that sound fair? You will have weekly online quizzes every single week of class. So at the end of this class, you will have a weekly quiz. It's open book. Use your resources, but it's timed. You get 15 minutes for the 5 questions. You have to study before that quiz, because if you think you're going to spend those 15 minutes looking up each of those 5 questions, I can guarantee you, you won't do well. Because those 5 questions are going to be over the content we covered in 60 slides worth of information.
Are they in special answer form?
No, they're all NCLEX style, multiple choice. There won't be any select all that apply. They're fairly straightforward. It will be content that we covered. I can't necessarily tell you that there won't be more specific information that will help you. That will be in your textbook. So I would advise you, review the PowerPoint slides. Go back and pick out sections of the text that look like they apply to what we've talked about. Review that material, so if nothing else, you know where to go when you say, I got it down to 2 answers, I don't really know which one it is, let me go back and look. These quizzes are designed to do 2 things. One, they tell me whether or not I covered the information well. If all of you bomb them, obviously I didn't do my job. If it's kind of a mixed group, what that tells me is that some of you studied really well, some of you didn't, or that you guys really suck at NCLEX style questions. One of those 3 options. Usually the NCLEX style has some component to it because as the class progresses, the grades get better. Every time I've done these, that's been the trend. The first couple kind of hurt a little bit, and as the semester goes on, they get better. If you look, those weekly quizzes over the course of the entire semester get added together as 1 grade. They're going to total 45 points. So you'll have 9 quizzes at 5 points each. But when you look at the impact that each individual quiz has on your grade, it's not that big. So when you freak out because D2L shows you that you got a C because you got 1 wrong, which amounts to an 80, it's not that you got a C. It means that you missed 1 point out of 45. It freaks everybody out. I wish I had some other way to set it up so that D2L didn't do that. If you would like, I can take it away and not have it put the little C and not make it change the little color if it'll make you feel better. It's the same thing either way. But you let me know. If it totally freaks you guys out, if you miss 1 question, I will be happy to get rid of the colors. It's totally up to you. But inevitably, that the first week or 2, it's a bit of a learning curve. It takes people a little while to kind of get used to it. And as the semester goes on, it gets better. Typically, when you look at the overall grade of that 45, it's better than any of your in-class exam grades because you've had the book and your study guide and your PowerPoints and everything else at your service. So use them. It's designed so that you're not sitting down at exam time trying to cram all of this information. It's trying to sort of get some of it to stick as we go along. So, the maternity case study. For this assignment, I'm going to provide you guys with a case study regarding some component of maternity care. Again, when this case study is due is listed in your syllabus under that course calendar. I think it's close to when that midterm happens, so that basically we've covered all of maternity before you've got to sit down and try to analyze it and come up with answers. The case study will be provided for you. It will be located on D2L. I haven't gotten it up yet. Don't get your panties in a bunch. It will be up there, I'm hoping, by the end of the week. With this case study, there will be a series of questions that you guys need to answer. I cannot stress enough, your answers need to be very thorough, but concise. Do not write me 5 pages on 1 answer. Give me all the information I need, but summarize it and shorten it up. Give me what I'm asking for. Don't give me lots of extraneous information, because what that tells me is that you're not really sure of what the actual answer is. So narrow it down to what the question is actually asking you. The information that you are to include in your answers needs to be cited with references provided. Because while I would love to think that you are all geniuses, I know that you don't know that much about maternity nursing and that you didn't come up with that information yourself. It came from somewhere. In these answers, there need to be at least 3 sound, reputable, and reliable sources. Wikipedia does not count. If you're using things like the CDC website, that's fine. If you're using journal articles, that's fine. If you're using your textbook, that's fine. But they need to be 3, so it can't just be that you're only looking at your textbook. I want to see that you guys can start to look into what information is available to you outside of what we're providing. Grammar and spelling absolutely will be included in your overall grade, because as nurses, you need to be able to write. I don't expect you guys to put together an entire graduate thesis-worthy composition, but it should make sense. You should know how to use periods and commas and capitalize your letters and spell properly. Knowing the difference between there and there and there. Okay?
I have a question about the APA format. Are you going to be looking for that double space and like the double?
No. As far as APA goes, the only thing I want to see is that your citations are APA appropriate. That's it. I'm not expecting you guys to know the ins and outs of APA by any means. The answers, there's not a page limit as far as this case study goes. I don't care if it's double-spaced or single-spaced. It just needs to be typed because I don't want to have to try to decipher your handwriting. And I don't want you to lose points because I thought I read something differently than it actually said. So do you guys have any questions on the case study? I don't know how many questions it is yet. I honestly haven't written the case study yet. So that's kind of on my to-do list for this weekend.
So some of the APA quotations, it says that the quotations
correct.
Paraphrase, but I have experience with instructors do like that. What is your...
So as far as your answers go, if you're going to use quotations, keep them brief. I want to see that you understood the information. I want you to be giving me the answers. So if you have a phrase that you can't figure out how to reword, quote it. If you're going to do that, make sure there are page numbers. If you're just going to cite it because that's where your information came from and you paraphrased it accordingly, just cite it at the end of the paragraph and that's fine.
Does it need to have like a hanging indent or anything like that?
No. Okay. No. I mean, I'm not really looking for intense APA with this case study at all. I want to see that you can take the information that we've learned in class, take a real-life scenario, and critically think to get your answer. It's going to be stuff like, this is your patient, these are their vital signs, this is what they're complaining of, here are your questions. What are you concerned about? What's going to be your priority? Where are your first actions? Basically the same stuff that they're looking for on the board, but in paragraph form without a multiple choice where you actually have to give me the information. Okay? For your pediatric health promotion project, this is where I really enable you guys to find your creative side. I am not a creative person. You will notice my PowerPoints are extremely boring. They're words on a page. That's about the extent of my creativity. So I don't want to hone all of you into that restriction. Nursing requires some component of flexibility and some component of creativity, and so I want to give that back to you guys. I want to encourage that side of you. So what this will entail, and this again is the pediatric side of things, we're going to pick a topic, a diagnosis, a treatment, some kind of a therapy, something that we've talked about in the pediatric component of things, and you pick that topic. I'm not giving it to you. Pick something that you find interesting, except for the fact that it has to pertain to nursing care, something that nurses are going to be doing. So whether it's diabetes education, or it's wound care, or it's education about nutrition, or, I mean, there's a million different topics that you guys can come up with, but it's something that has to pertain to things that we are going to be encountering. And it's important that the topic's relevance to education or health promotion is clear. So it's either education that you are providing, or it's an element of health promotion in order to get somebody to live a healthier lifestyle. What you're going to do is you're going to pick 3, again, sound, reputable, reliable sources, and you're going to use that information to create this project. Now, this project can be a pamphlet, a video, a PowerPoint presentation. It can be a poster. It can be a flyer. I don't care. Be creative. I don't want 20 flyers or 20 trifold little things that you can make on Word. They're boring. They get old. Be creative. I've had students that have made videos. I can put up, if you guys will remind me as we get closer to this, there are certain sites that you guys can use online that help you to create videos, cartoons, or videos that like they've got on YouTube. I mean, there's a ton of this stuff out there. Use your creativity. The more creative it is, the more enjoyable it is for me to sit and watch. The more enjoyable it is for others to sit and watch it as well. the key part of this is that you have to pick a developmental age. And we'll cover this when we get to pediatrics. The first 2 weeks of our pediatric section are solely based on development and milestones and things that they're afraid of and expectations that you have of certain age ranges, things like that. So you have to pick a very specific developmental target, whether it's toddlers, school-age kids, whatever it may be, and pick a topic that's relevant to that age and make your project applicable to them. You know, I've had some really cool presentations. I've got a couple of examples still in my office from last semester. I had a girl that put together a thing about brushing their teeth, and it was on a big trifold poster, and she's got a big smile, and it's behind this plastic sheet that you can, like, paint green, and they take a toothbrush and actually, like, scrub the teeth off. Great idea. Something a 6-year-old or a 5-year-old would think was awesome. You might actually get them interested in it. Tweak your project so that it actually applies to that developmental age. And then you have to add a supplemental 2-page double-spaced paper, so not a ton of information. But in that paper, it's got to include information about the particular developmental age you are targeting, what you would expect of that age, and what you did with your presentation to target that age range, to apply it to that group. Does that make sense? Well, again, come to me if you've got questions, if you want to make sure that your idea is going to work. I'm here. But it should be fun, you know, make it fun. And then making sure you're using your citations. Again, I'm not stressing APA, but you have to cite where your information came from. Otherwise, it's considered plagiarism, even if it's not word for word. So make sure you have citations in there. But again, I'm not docking you guys points on strict APA format. And make sure it's appropriate and engaging. Make it fun, because it really gets boring sitting and reading the same pamphlet 18 times.
So this isn't something we're going to share with the class?
I haven't decided yet. A lot of it will depend on how much time we have come the end of the semester. I would love that if we have time towards the end of the semester to have you guys get engaged and bring them in. What I'm thinking of doing, and I haven't quite decided, depending on how long the presentations are, since there aren't a ton of you, after the final exam, I'll likely have you present them to everybody so that it's not just doing work for no benefit. And then if you guys are amenable, I've had a couple of students in the past that we've been able to utilize their projects in the community, either at the public health department or at the dental school. I mean, we've had the ability to actually put them into practice. So if you guys are open to that, I'm more than happy to put them into practice so your work isn't just for a project grade, it's for something actually practical. Okay? Any questions?
For us distance students, how do you want us to take the exam?
So what we did last semester is the student I had who was distance would get a proctor for each exam, and then we'll have the proctor there, but it'll still be in the lockdown browser, so you'll have to have the camera and stuff so that we can see you. But that'll kind of be the plan. If you guys are having trouble getting proctors, or, I mean, just keep in touch with me. I'm pretty flexible with that kind of stuff. And then as far as the timing of the exams go, we can kind of adjust a little bit here and there. Obviously not enough that you can give answers to other people, but the other thing I'm glad you brought up, you don't get your exam grades right away. It closes out and you're done. And I do that on purpose because after the exams are all submitted, I go back and I spend a fair amount of time reviewing every single question. And I look at the statistical analysis behind it to figure out if it was a good question, why people didn't pick the answers they should have, how the class performed as a whole. Did the people that do really well on the exam, did they get the question right? And if they did, then it's a good question. It might just be a really hard question. The statistics behind each of those that D2L provides is actually really nice because it tells me that. It gives me the information I need to know to say, I didn't cover that well enough in class. That's on me. So I go back and I evaluate all of that before I make the grades available to you guys so that if things have to swing drastically, the grades don't come out and have you guys go, what happened, and think you need to go get a job at Starbucks. So I take the time to review all of that before the grades get posted so that the grade you actually see is a true reflection of how you did and how I did. Because it's not fair for you guys to get penalized if I didn't cover something effectively, even if it was a good question. Typically what I'll do is after I've done that, I'll make them available to you guys for a brief period of time so you can go back and review and see what you got wrong. Because even if I give credit back for questions, it'll give you the correct answer so you can see what you should have picked so that on the next exam that's cumulative, you at least know where you went wrong so you're not studying incorrect information. Typically what I'll do is I'll make them available again to study from before the next exam if you guys would like that. I don't reuse questions, so there is no point in memorizing, there's no point in writing stuff down. Everything gets started from scratch when I make the next exam. So content-wise, it's great, but don't try to memorize questions because you'll sink. Okay? Does it sound as terrifying and as awful as all of you have heard? Okay. It's hard. I'm not going to lie. I mean, this class is hard, and it requires a lot of work on your part, but it's doable. It's daunting. I'm not going to lie. It's overwhelming when I sit down and put together all of this information, and it floors me. You have it all smushed into one class and not two. So I get it. I'm there with you on that one. But you guys can do this. And I'm here to help you do this. Okay? I'm not a scary monster, I promise. Not all the time, anyway. Okay, so we're going to dive into the actual meat of the coursework now. And I hope you guys have access to your PowerPoint. So, evolution of nursing. I'm sure that you guys have talked a little bit about this in each of your classes, but we're going to talk about it more with the specifics in how things have changed for women and children over time. One of the big things that we've seen change are methods of childbirth. So back in colonial America in the 1800s, pregnancy, birth, that whole process was an anxiety-producing diagnosis. Obviously, they wanted to procreate, they wanted kids, they wanted to expand their family, but the thought of that whole process to get to that endpoint was terrifying. And it was terrifying because the mortality rates of both mom and baby were so high. I don't expect you guys to know exact numbers. They change. I'm not a big numbers person. I'm not a big specific, in 1902, this is what happened. But I do want you guys to understand the trends of how things have changed. So pregnancy in general was very anxiety-producing because the complications and the mortality that we saw associated with them were astronomical. It was something like 1 in 6 people died in childbirth. I mean, the numbers were fairly high when you think about it. I mean, that's a third of our class. In the early 1900s, things started to shift because what we had in colonial America was there was a lack of formal training. You know, the grandmother down the way who had delivered all of her sister's kids, who delivered all of their cousins' kids, who then delivered all the neighbors' kids, who then delivered all of her own kids' kids, and that was the training they got. They learned from experience, they saw what they saw, and they troubleshot. You can imagine that things would go awry if that's how nursing school was created, right? So what happened in the early 1900s is that we started to see an influx of physician-assisted birth. So now we have people that are formally trained. Midwives were people that were more informally trained. Again, it was kind of that generational, or they knew somebody who had done it a lot, or they would practice underneath a physician. And midwives were used for those people that couldn't afford a doctor. So again, you can imagine that the wealthy had slightly better outcomes than the poor. But it was also a sign of affluence if you could have a physician deliver your child. It was something to be proud of. We did have a high mortality rate in the maternal world when it came to postpartum infections back then, because hand washing was not something that was overly emphasized. You know, you think about when Nightingale really kind of came to fruition, you know, it was the early 1900s. And so you might have had this pride in having a physician deliver that child, but it didn't mean that the outcomes were any better when it came to things like postpartum infections that people would die from, because they didn't have the ability to administer antibiotics the way we do now. In the 1950s, now we've kind of flips again, and you get this resurgence of this concept of natural childbirth practices. This is when you started to hear a lot about Lamaze and doulas. While it was something to be proud of that you could afford a physician, people started looking at delivering a child and being pregnant as something natural. It's something people did. You hear about it all the time, right? People have been doing this for hundreds of thousands of years. It's a natural process. I'll put a caveat in. This whole semester, you will find that there is a slight influence in my NICU perspective on a lot of these things. So there's a little bit of cynicism when it comes to the non-hospital alternative. But it's because I'm jaded. And I will own that 110%. I'll give you all the other information as well, but understand that I'm very much aware of my personal perspectives on it, and it has only to do with what I've seen in my work experience. That doesn't necessarily mean that my opinions and my perspectives are right. Don't hesitate to bring up those other sides if you feel like I'm pushing too far one way. So in the 1950s, we did see this swing of this natural childbirth practices, and currently what we're seeing is kind of the peak of that pendulum. We're seeing a ton of midwives and doulas. Doulas are non-medically trained birth assistants. They're there to help the family emotionally, psychologically, to help counter that side of pregnancy, to kind of waylay those anxieties and those fears that a lot of people still have, even though our mortality rates have gotten much better. I will tell you, our mortality rate in this country is not much better than some third world countries. We have one of the lowest outcome rates, or one of the highest mortality rates when it comes to postpartum, intrapartum, antepartal, maternal deaths in the developed country, in the developed world. We're one of the worst. So there's something to be said about how we have managed our healthy patients. And there's a lot of reasons that go into it. And as we go on, part of it has to do with our C-section rates. Part of it has to do with our patients a lot of times are higher risk because they're not healthy to begin with. There's a lot of factors that go into it, but our care on the nursing end of things has a lot to do with it as well. So we are seeing a big peak in things like childbirth choices based on what works best for the mother. We're seeing a lot of birth plans. I will tell you from the NICU perspective, the more intense a birth plan is, the higher the odds are it's not going to be followed because that baby will have other intentions. That being said, birth plans are great because they help a family come into this very anxiety-producing process with a level of calm because they know what to expect. You know, they've got some element of control. The big thing when it comes to birth plans and birth choices is that we as providers need to make sure to educate our patients that while it's great to have those choices, there needs to be some element of flexibility involved in order to accommodate for the health and welfare of the couplet, of the mom and the baby. So again, it boils down to making sure that we're doing our part antenatally before they are at a delivery standpoint. And the other component of that is what works best for the child and family. You know, it may work better for the family to deliver in a birthing center where they're allowed to have as many family members as they need to or want to in the room. It gives them some element of control without necessarily having to follow all of the strict guidelines of being in a hospital setting. You know, we kind of have to keep our eyes open and stay non-judgmental when it comes to that kind of stuff. So supporting the family. The biggest take-home with that is that our role is to provide every family with all of the education they could possibly need in a non-judgmental and a non-directive manner. We shouldn't be telling them what to do. There's a big push in family-centered care that says every single family, regardless of the makeup, regardless of the composition, regardless of the education level, if you can supply them with the appropriate education at the appropriate level for them, that they will make the appropriate choices for their family. And that's hard when you come from our perspective, teaching somebody that, in theory, probably doesn't know much about this world at all. And it's something that applies to everywhere. It's not just to maternal nurse. That's a big take-home for you guys outside of this classroom. because everybody deserves that treatment. Everybody deserves this concept of family-centered care that's very focused in our world. Because if you can treat them as a family and you can treat them in their social environment and you can provide them with those resources, odds are they're going to do better for themselves. Odds are you're not going to see them readmitted for non-compliance. Odds are you're going to see them recovering faster in the rehab facilities. You're going to see them recovering faster and getting out of the nursing homes or thriving in the nursing homes, depending on the setting that you're talking about. Social trends that we see. So prior to World War II, hospitals were where people gave birth. That was it. There was no choice. It was you were going to deliver, you went to the hospital. There was a major shift in focus of care of late, rather than having the moms in the hospital for days on end. Now our focus is get them in, get them out. But we've got to teach them the same material in a much shorter, much more condensed period of time. Back prior to World War II, they would use, I'm blanking, what it was, ether to sedate moms during labor so that they wouldn't remember the pain. But it would knock them out so much for 24 hours that they couldn't take care of the baby. That's where nurseries came from. That's why they had nurseries. That's why they had nurses to take care of the babies, because the moms were so out of it they couldn't. Obviously, things have changed, and nowadays you're seeing this big push for LDRPs, labor, delivery, recovery room, postpartum, all in one room. And the purpose of that is so that there is no nursery. Babies are left with that mom, with that family, the entire time, so they have to learn to care for that child. It also alters our role as a nurse, because you have to take the initiative to go in that room. Most postpartum patients do not ask for enough help because they don't realize they need it. They don't realize when things are going wrong. They don't realize when things aren't successful because they've never done it before. Or it's the only thing that they've known, and they did it wrong the first 3 times, or they tried breastfeeding the first time and it didn't go well, and so the second time they said, screw it, I don't even bother. And it's because nobody took the time to go in and help them. So it very much alters our perspective of waiting for that call light to go off, and it forces you to go into that room. You have to take the initiative because they aren't necessarily going to ask for help. Again, kind of bringing up that concept of breastfeeding and rooming in. 40 years ago, breastfeeding was not the in thing. People their kids were formula fed. Breastfeeding was kind of like, now you see that reaction. People are like, I'm going to bottle feed. It comes full circle. Healthcare in general is this concept of a pendulum swing, and we're just at the peak. I guarantee you over the next 15 to 20 years, we'll see it swing all the way the other way. It's just a matter of time. In the 1960s and 1970s, that's, again, kind of with that introduction of natural childbirth practices. In the 50s, we started seeing things like home birth, prepared childbirth, so those birth plans, having the dad involved. Before that, the dads were at the bar down the street waiting for the news that their kid was delivered, and it was the grandmother in the room. The dads weren't there. It wasn't something that they were really into. You only just started to see that resurgence in the 1960s, 1970s, and it was like that even back in colonial America. They were out in the field doing what they needed to do, and it was all of the women delivering that child. The dad only knew whether or not everybody survived after the fact, when everything was okay or not. We don't do that anymore. We want that dad right at that bedside. Again, a big nursing piece, because typically it's the biggest guys that go down the hardest. They turn white as a ghost and they're out. And now you've got 3 patients to take care of. You've got that mom, that unborn child, and the dad that's passed out on the floor. So being situationally aware, not just pigeonholing yourself and staring at one problem, but being able to open your perspective. There's a reason that this is not the first class that you guys take. You have to be able to look at the big picture. Epidemics, things that we look at. Immigration has a huge impact on infectious disease and epidemics in this country. A lot of it has to do with vaccination. A lot of foreign countries do not have the same vaccination policies that we do, or the vaccination abilities that we do. So you see this influx of diseases that either we're ideally immune to, or that our bodies have never been exposed to before at all. This is becoming more of an issue now with people not vaccinating their kids. because there's plenty of diseases in this country that are basically eradicated. We don't see, or we didn't used to see measles at all, because kids were vaccinated. You know, our generation, everybody was vaccinated. It wasn't a big deal. It just was done. And now there's a big push, and we see a lot of people that are the anti-vaxxers. It's the negative propaganda that goes along with it. And there's a cultural component to that. And we have to learn to respect it and understand it, but also be able to educate for the counter as well. But measles is coming back, and it's coming back because we have people that aren't vaccinated. We don't have this herd immunity anymore. So all it takes is one person coming in from out of the country that wasn't vaccinated, that has measles, that gets in and around other people, and now that one person is able to infect multiple people because we have people that are not immunized against it. Public health efforts are things that have actually continued to increase. Things like safe milk supply, so homogenizing milk. That didn't always used to happen. You know, when the milkman came with the glass bottles of milk, it wasn't pasteurized milk, necessarily. It could have been from the cow down the street. It tastes the same, in theory. I can't honestly tell you because I've never had non-pasteurized milk, but this concept of safe milk supply, the FDA now regulates that any kind of milk for sale has to be pasteurized, has to be homogenized, that sort of stuff. So we start looking at mandating rules and restrictions for the welfare of the masses. And then compulsory vaccination programs. So to be in a school program, in most schools, kids have to be vaccinated. There's a lot of daycares that have those same requirements as well. Healthcare systems, we've talked a little bit about this, the conventional institutional setting, the home birth, and the birthing center. Each of those comes with its own pros and cons. In the conventional institutional setting, you have everything at your disposal. If anything goes wrong, you have the ability to fix it, to intervene. The downside to that is oftentimes women are restricted on movement in bed. Typically, they have an IV, an epidural, they're lying in bed, and that's what they say. They're not up and moving around. Their mobility is restricted. Their ability to have family members present is usually limited to a certain amount of people during a certain period of time. If kids aren't vaccinated, they're not allowed to be in there. I mean, there's a ton of restrictions that go along with it. So there is a pro and con. Home births are kind of the absolute flip side of that, where if something goes wrong, they have nothing at their disposal. Nothing. You think about some of the places in this state and how long it can take to get to a hospital. You know, if we're looking at Chodo or Conrad, those are places that can deliver babies, but do they have all of the same resources that Great Falls does? Absolutely not. So if you have somebody that chooses a home birth that lives 40 minutes away from Conrad, and now something goes wrong at home, now we have an ambulance ride to Conrad, where you hope that things are starting to get better. They get to Conrad, we hope that they have the resources to be able to stabilize that patient and improve things. And if not, now we're talking about a helicopter ride all the way down to Great Falls. That is a long period of time for things to go wrong. So there is a downside to home birth. The upside to home birth is that the family gets to control everything. They can eat when they want, they can pee when they want, they can walk when they want, they can get in a bathtub if they want, they can have all of their family members there if they want. There's no restrictions. It's all in their own plan. They can have whatever music playing they want. They can, you know, use herbs, and they can, I mean, there's anything that they can imagine they can do. So there is a definite upside to that, because it enables people to have a control over the psychological element of childbirth that you don't necessarily get in an institutional setting. Kind of the intermediary is this birthing center concept, and we're seeing more and more of these nowadays. Birthing centers are kind of in between. Typically they're run by midwives. They're not physicians. So surgery is not an option. So if they need a C-section, they're shipped to the nearest hospital that can do that. Here in Great Falls, the birthing center is down 10th Avenue. So if something is going awry and that mom needs an emergency C-section, how long do you think that ambulance takes to get from its bay to the birthing center and back? It could take 20 minutes round trip, pretty easily if you think about it, and that's assuming there's no traffic. You guys have all seen what the traffic on 10th does when an ambulance is coming by. It's kind of like a cluster of people trying to rear each other into some direction in the hopes of sort of getting out of the way. A lot of places nowadays are building birthing centers attached to hospitals, so that families can have the ability of a home-like setting knowing that the resources, if something were to go awry, are close. Now, in a birthing center, they can do things like IVs, they can do fluid, oftentimes they can do pain medications that way, IV routes rather than just orally. So families have a little bit more at their disposal, but not quite the amount that they do at the hospital. And as far as interventions go, again, they can get things like fluid boluses. They can intervene in the interim while they're waiting to get to the hospital. So they're not quite as stuck as they would be if they were at home, because you have somebody who's trained to manage those situations. Birthing centers will not take high-risk patients because they don't have the resources to be able to support them should things go awry. We've got a couple of midwives in the community that actually do home visits as well as that do home births, that have the ability to do a little bit closer to like what a birthing center would. They've got the ability, they kind of carry like a big pack with them that has, a mobile transportation of resources, oxygen, things like that if baby comes out and is depressed, things that they can do kind of to intervene in the interim. Does that make sense as far as the pros and cons of each of those? Certified nurse midwives, these are people that have received postgraduate training, so they've already received their RN and they are now going back for further education regarding the care of normal pregnancy and delivery. Again, they do not take high-risk patients, and we'll talk more about what that definition means next week. Doulas, we did mention already, and then a vaginal delivery versus a C-section. We're seeing a lot more elective inductions nowadays. People get to 39 weeks and they schedule their date. They don't wait for labor to happen. Again, this kind of has swung in the pendulum, and we're starting to see that decline. We're starting to see more people deliver post-date. But back probably 20, 30 years ago, we saw it a lot more often where you didn't have a ton of deliveries during 4th of July week or during Christmas or New Year's, because people were scheduled for C-sections because their physician was going to be out of town or on vacation or whatever it might have been, because it was convenient. Insurance companies rather quickly put a kibosh on that when they started realizing it wasn't in the child's best interest.
We'll talk about the negative effects of going past your unit.
Yeah, we'll talk a ton about that. We actually, I think, have a whole week on kind of the downsides and the complications of things. Pain management, again, there are a lot of varied choices, and we will talk a ton more about that as the semester goes on. And then birth plans, which again is just a way for a family to maintain some semblance of control through this rather trying and uncertain time in an environment where they feel like they have no control at all. So they can be very beneficial, assuming we educate them in advance that they are going to have to maintain some level of flexibility when it comes to the health and well-being of the couplet. Regulations, a lot of it boils down to things that we see federally mandated. We look at things like helmet laws, car seats. You see there's a big thing in the news with Detroit and their water situation with the fact that there was a ton of lead in their water system in the outskirts of Detroit, and it was causing a lead toxicity in kids. And the federal government had to step in order to figure out a way to change things to make it safer for everybody. All of these things have helped us change the amount of disease-causing deaths that we see in kids. So now what we see is that unintentional injuries, so falls, shaken baby, SIDS, those sort of things, are now surpassing disease as the leading cause of death for kids that are over a year old. Under a year old, those numbers haven't changed drastically, and we're still looking at things like SIDS, low infant birth weights, congenital heart disease, things like that. Technological advances. Now this plays an interesting role because it has increased our survival rates. So in theory, has improved our mortality rates. But because we're attempting to save children now that have higher disability potential, that have higher potential for a later demise, we're saving kids that are 22, 23 weeks gestation. those babies, their chance of survival is so much lower. So now we're skewing where our mortality rates are. Is it considered a, I'm blanking, a fetal demise, so a baby that never lived? Or did we save it and now it's 30 days out and passes away, and now we have an infant death? Our mortality rates have kind of shifted, but it's not necessarily that our numbers are changing all that drastically because of how we're evaluating it. The other thing that we're starting to see is that we're getting a lot more kids with chronic disabilities, much higher acute patients that you guys are taking care of, in the home health care setting. Those kids are not benign. I mean, they are seriously complex kids, with trachs, with G-tubes, with, respirators, with vests. I mean, there's a lot of stuff that goes along with some of the kids that we see in the community. And so what we've seen now is because of this prognosis, because of this increase, we're seeing a lot of national and international organizations that are standing up for children's rights, that are giving those kids a voice, that are giving the 22-weeker a voice, that are giving the 5-year-old with CP a voice. There's a lot of that coming in the news right now with our shift in healthcare, because all of that plays a big role.
Does the parent get to decide, like if a baby is born and we know that it's going to be
like resuscitative effort?
Very acute disability child, does the parent get to decide and let it go?
Mm-hmm. Yep. It's a big discussion. It's usually a big family meeting, a big education piece, but I've been in numerous antepartum rooms where mom's in labor at 23 weeks and 1 day, and the neonatologist is in there saying, we're willing to do everything. What do you want? These are your odds. These are the statistics. I can't tell you that these statistics are going to tell you what your kid's going to have. Your kid could be fine. Your kid couldn't be. But it boils down to making sure, again, that family-centered care concept, that you're giving them all of the information that they need to be able to make the best decision for their family. Yeah, I mean, we have those conversations a fair amount in the NICU. The hard part is, when you look at a baby, you don't expect a lot of the baby. They need to eat, poop, and breathe. That basically brings them functioning when you think about it. So looking at a baby doesn't necessarily tell you, even if they look perfect, doesn't tell you that at 15 that kid's going to be getting ready to drive. There's no way to correlate what you're looking at right now with their prognosis. And by that same right, there's no way for you to look at a baby and say, that kid's got a grade 4 bilateral bleed, they're going to have CP and never walk. I've been in conversations with families like that where physicians have said it, and I will guarantee you to this day, if they've got a good, supportive, strong family, you can't put limitations on a kid, because it's amazing what they can do. So they're hard conversations to have because nobody's got that crystal ball. Yeah. No, thank you for clarifying. You'll find I do that a fair amount through the semester, so please ask. Preventative health care for women. This one's a big one. Table B3.1 in your book, which actually I think is online. The bonus chapter you only have access to online, but it is the content that we're going to be covering probably for the next 50 minutes. When we look at preventative health care for women, it becomes an important topic because women really are the matriarch of the family unit when it comes to healthcare. Women are the deciding factor. They've found historically that they are the ones that determine the health outcomes for the whole family. So their ability to get kids to doctor's appointments, their ability to take care of themselves trickles down to how their kids take care of themselves. Typically, if they're not taking care of themselves, the male figure in the family isn't taking care of themselves. It all kind of formulates around that one singular unit. And it's interesting that in such a male-dominated society that matriarchal position has maintained its strength. So we need to make sure that we are focusing our efforts, especially on preventative health care for them, to make sure that the health of the family is maintained. They tend to put children and families first. They tend to kind of let themselves go by the wayside for the salvation or the priority of their families. And as a result, they may actually go years without a physical exam or any kind of preventative screening because they feel fine. Or it's not their priority because they've got to get their kids to the doctor or they've got to get their kids to school and they just don't have time and they're working 2 jobs and they're doing a whole bunch of different things in order to try to stay afloat. So their health kind of takes a back burner, goes to the back burner. So things that we need to promote for women are going to be things that help to improve their health overall. Eating healthy foods. My Plate is a big resource for you guys. You really will benefit yourselves to study it when it comes time for your boards because it'll help make things kind of come together. Maintaining a normal weight, and typically this is looked at as far as BMI goes. 21 to 25 is usually the range that we anticipate people being in. Having them exercise daily. Usually they say getting a cardio intense workout for a half hour 3 times a week is what we target for. But ideally, we'll have them doing some kind of physical exercise every day. It doesn't necessarily have to be cardio. It could be lugging their kids to and from the car 12 times. Sometimes we need to be able to be creative in our suggestions as well when we're talking to families to make it applicable. Give them a reason, give them hope, give them something to strive for that means something to them. Practicing safe sex, we're going to talk about that here in a little bit. Avoiding tobacco products, limiting alcohol intake. You notice it doesn't say eradicate alcohol intake, it just says limit. And then encouraging them to obtain preventative care. Table B31 is going to go through some of the health screenings for women that you guys need to know. Typically, if there's a table or a box or anything that's on these PowerPoint slides, I'm not going to go into grave detail about it because your book does a really good job. So make sure you use that as your kind of key resource, like a big flag to say, I should go back and look at that when you're going to review your slides. Because it'll give you a little bit more information about the types of, or examples. Do you guys have any questions about that? Okay. Then we're going to jump into the reproductive system. How much exposure do you guys have to this so I know how in detail I need to go? Is this a review? Is this brand new? Review? That's the general consensus? Okay. So, as far as the female reproductive system goes, you need to know what the organs are and what their purpose is. So the vulva is a collective term for the external female reproductive organs, and there's a picture, I think, on the next slide. Yep. It includes the mons pubis, the labia majora and minora, the clitoris, the vestibular structures, and the perineum. Its purpose, its sole role is to protect the urethral and vaginal openings. The other component to it is that it's very highly sensitive and it's the source of increasing pleasure for the purposes of arousal. Our population would not exist if sex wasn't fun. That's the whole role of the vulva. So, for you guys, the mons pubis is that elevated, roundy prominence over the symphysis pubis, and its sole responsibility is to provide padding during intercourse. If you were mashing 2 bones against each other, it wouldn't feel very good. So they put this little fat pad in there, this fleshy prominence, to give it some cushion. The labia majora literally are the larger external lips. They have the sweat and sebaceous glands. They, in fetal development, start from the same tissue that creates the scrotum. They are one and the same. When we have a child that has ambiguous genitalia, it's in part the labia majora and or the scrotum that have trouble differentiating. The labia minora, they're the ones on the inside, and they are the hairless inner folds of skin that are highly vascular, highly innervated, so they're very sensitive, and their function is to produce lubrication. They swell in response to stimulation. They're highly sensitive. They're very similar to the erectile tissue on the penis. If you're noticing, most of these functions all relate back to the fact that sex has to happen for life to continue. The clitoris, the sole role, the sole function of it is sexual stimulation. The prepuce, which is basically the hood that goes above the clitoris, is there to protect it because the clitoris is so sensitive. The hymen, now this one's an interesting one because there used to be a very large emphasis placed on evaluation of a hymen to know whether or not a woman was a virgin. It's the tough elastic tissue that is perforated that covers the vaginal opening. The other term for the vaginal opening is introitus. You'll hear that or you'll see it on slides or on your exams. You're expected to know that those words are interchangeable. In a virgin, in theory, that hymen is going to encircle the opening like a tight ring. So basically, it's nice and solid and smooth. Now, after they've lost their virginity, what we see is around that ring is now this tissue has gotten torn, and so it's got small tags on it. Tampon usage can cause that. Horseback riding, gymnastics, bike riding. I mean, there's a ton of different activities that can cause the hymen to break or to tear like it would with intercourse. So really, the terms virgin and non-virgin are kind of an unfair descriptor for this. But it is important for you guys to be able to know the difference, although I will tell you, trying to figure out how to do that on an assessment, God bless if you can figure it out. Because none of it ever looks like it pictures in your textbook. And then the perineum. This is going to be the area that's most posterior. It's what connects the vulva and the anus, and it's just skin that covers muscle and fascia. The important part of the perineum is that in our world, it's the site of an episiotomy. That's where they snip to make that vaginal opening larger to be able to pass the fetus's head or shoulders or whatever it may be. I will also tell you that if you ever hear the sound of an episiotomy, you will never forget it because it's awful. It's a clipping sound. It's just not, there's no way to describe it, but if you've heard it, it's one of those, it's like nails on a chalkboard, you'll never forget it. Vestibular structures. So the vestibule is the area in kind of the diamond shaped on your slide. It's perforated by 6 different openings. You've got the urethra, the vagina, Bartholin's glands, there's 2 of those, and Skene's glands, there's 2 of those. So that's why there's only 4 points, but there's 6 openings. The Bartholin's glands are located beside the introitus, and their purpose is to secrete lubrication during intercourse. The Skene's glands are up a little bit higher, and they are on either side of the urethra. And what that does is it actually secretes a very small amount of mucus that keeps the opening of the urethra moist for the passage of urine, so it doesn't actually damage the skin or the tissue. So internally, this one gets to be very important when we jump to next week when we talk about pregnancy. You have to know where all of these structures are internally, because if you know where they are, it makes the understanding why we see the symptoms that we do so much easier. It allows you to be able to not memorize. So if you can understand physiologically how things are shifting and where they're putting pressure and that sort of thing as a fetus is growing, you don't have to memorize which symptoms you see during which trimesters and so forth. So if you look, you've got the uterus, and it'll be easier if I stand over and show you. So you've got the uterus, right? And it's sitting directly posterior to the bladder. So you can imagine as that uterus is starting to grow, before it actually rises up and out of the pelvis, it's putting all of that pressure on the bladder. So if you can remember where the uterus is in relationship to that bladder, it'll help you along the way. So the bladder's in the front, the uterus is in the back, and then the rectum is sitting directly behind it. So the uterus is basically sandwiched between the rectum and the bladder. Again, which will help to understand why we see the symptoms we do in pregnant patients. On this side, you've got the uterus, you've got the fallopian tube, and the actual ovaries themselves. And we're going to talk about their function and purpose here in just a second. So the vagina itself is a curved structure that connects the uterus itself to the external vaginal opening, to that introitus. It's got a mucous membrane that has rugae in it. Rugae are those ridges, right? Kind of makes it like an accordion. Those rugae are what allow for the extreme distension that we see of that vaginal canal during labor and birth, because nobody walks around with a vagina that's 10 centimeters big all the time. Okay? Those rugae are what allow it to expand and contract just like an accordion. Kind of a disturbing image when you think about it, but it works for a purpose. It also has a very acidic environment, and that acidic environment protects it from ascending bacterial infections. Because if you think about where that vaginal opening sits, do you think that's sterile? No. So having that acidic environment enables it to stay healthy. Things like antibiotic therapy, douching, perineal hygiene sprays, deodorants, all of that stuff can affect the balance, the pH balance within that vaginal canal, predisposing it to further infections. So things like antibiotic therapy. Oftentimes women will end up on diflucan or something like that after being on antibiotics, because the antibiotics have wiped out their normal flora, have altered that pH balance, and now yeast has been allowed to multiply and continue to proliferate and take over. Yeast is a component of the normal flora within that tract. Being on antibiotic therapy just allows for the eradication of everything else. Douching we don't recommend at all anymore. Perineal hygiene sprays, deodorants, all of that kind of stuff are big no-nos. If you see any of those as an answer, unless it's a what would you advise against, those are not going to be your choices, because those all damage that vaginal environment. The uterus itself is going to be a pear-shaped muscular organ that sits at the very top of the vagina, and it's not actually firmly affixed. It's anchored in place by 8 ligaments, which allows it to move. The two big ones that are very important are going to be the round and broad ligaments, and typically those are the ones that people complain about during pregnancy. Oftentimes, a woman will come in complaining of this odd pain kind of going along the femoral artery. They'll go to get up and all of a sudden it's like a pull, or it stings, or it feels like something got ripped. And it's that round and broad ligaments that are shifting and stretching in order to accommodate the growth of that uterus. The uterine wall itself is comprised of 3 layers. You have to know these 3 layers. You have the endometrium, which is the innermost lining. It's mucous membrane. That's the part that, when we say innermost, we mean closest to the inside of the uterus, to where that fetus would develop. The myometrium is the thick muscular layer in the middle. And then the perimetrium, and that's the outer layer that covers the uterus that is exposed to the visceral fluid, to the rest of the abdominal cavity. There are 3 anatomic subdivisions of the uterus. I'm looking to see if there's a picture, which are important for you guys to know. The fundus, the body, and the cervix. So if I look back here, you've got the fundus up top. It's that arch. You've got the body, and then the cervix. It's important to note each of those areas, because depending on what we're talking about, it's going to very much tell you a lot about what our expectations are. For example, when somebody is going through the menstrual cycle and then their egg gets fertilized, we would anticipate that the ideal location for that egg to implant, for that zygote to implant, is going to be in the fundus of that uterine cavity. All stuff that we're going to talk about later, but again, it's more for you guys to be aware of a lot of this anatomical stuff so that when we're talking about it later on down the road, it makes sense. The cervix itself has an internal os, which is the opening that is on the inside component of that uterus, and the external os is at the bottom of the cervix, which is at the opening into the vagina. The cervix itself is going to change in length as well as width and thickness as the pregnancy progresses, and we'll talk more about that as we go on. But again, more of an understanding of how it's built so that when we talk about it later, it makes sense. It's got 4 functions. It's lined with mucus-secreting glands, and that's where the lubrication within the vagina actually comes from. It acts as a bacteriostatic agent, so those of you guys that have seen PICC line dressings or IV sites where they've got those little white rings over the actual insertion site, those are bacteriostatic. It basically means that it stops any kind of bacterial growth. So in theory, even if we ended up with a vaginal infection that, because of them douching or whatever it might be, in theory, that cervix should still serve as a stopgap so that infection doesn't continue up into the uterus. The alkaline environment, now you'll notice the vagina is acidic, the cervix is alkaline. It's alkaline because it actually protects sperm from the acidity of the vagina. So basically the sperm shoot through that vagina as fast as they can in the hopes of getting to the cervix so they've got like their safety net. That's where they reside now for up to 3 days, 3 to 5 days, they say. And then lastly, it produces a mucus plug during pregnancy. So it actually creates a physical barrier to that fetus from falling out. It's kind of the fetus's last effort if all else fails. The fallopian tubes are on either side of the uterus. They're extending out towards the ovaries in either direction. They're approximately 4 inches in length. And it's important to note they're attached to the uterus, but they are not attached to the ovaries. The ovaries themselves are actually suspended away from the fallopian tube. Their job is that after the ovum, the egg, is released from the ovary, they have these cilia, these hair-like projections on the very outside end of the fallopian tube, and they basically like wave the egg in, like, come to me, and the egg floats its way in, and it gets into the fallopian tube. The fallopian tube is the ideal site for fertilization. That is ideally where the sperm will meet the egg, not in the uterus. It then travels down that fallopian tube over several days as it's multiplying and dividing and growing before it implants. The fallopian tubes have 4 functions. Again, it's the passage where sperm meet the ovum. It's the site of fertilization. They create a very safe environment that's nourishing for that zygote as it's traveling its way down. And it's the means of transporting that zygote to the uterine corpus. So basically what we're seeing is it's got this peristaltic motion that's kind of just slowly moving that fertilized egg, that zygote, down its way until it gets to the uterus.
So we see those in the endoscopic pregnancy.
Ectopic.
Is that because that peristalsis isn't moving quick enough, or is it like multiplying too quickly?
A lot. What they've found sometimes is that it can be that the timing was off, and so it fertilized at like the upper end of the fallopian tube, and so by the time it was ready to implant, it hadn't quite gotten to the uterus yet. The other thing that we'll see sometimes is that'll happen with like scar tissue. So they've got scarring in the fallopian tube from repetitive STDs or from previous surgeries or any of that kind of stuff. It blocks that zygote's ability to get past effectively. Ovaries, so these are a set of paired glands. They're not organs or tissues, they're actually glands that are in the pelvic cavity. They are the equivalent to testes in the male. Again, they're not attached to those fallopian tubes. They are suspended in close proximity, and they've got 2 main functions. They are developing and releasing that egg, and they secrete estrogen and progesterone. That's their sole role. Estrogen is what is responsible for the stimulation for the development of those secondary sex characteristics. So we're talking about breast development. We're talking about pubic hair, armpit hair, that sort of stuff. And then progesterone. Progesterone is responsible for preparing and maintaining that lining of the uterus for implantation. That's the only thing that we see progesterone used for. So basically, through that menstrual cycle, progesterone is released by the ovaries in the hopes that that ovum is going to get fertilized and that zygote's going to implant. And so what it's doing is it's preparing for implantation. It's creating this warm and inviting environment with this very nice thick lining on the uterus, so that zygote's got a great place to implant and call itself home for the next 9 months. If that doesn't happen, progesterone levels drop off, and we see the menstrual cycle start. We see bleeding. And it's the shedding of that built-up lining that is causing the blood flow that we get in the menstrual cycle. Breasts. These are accessory organs. Their sole purpose is to secrete milk following pregnancy. The nipple itself is surrounded by a pigmented area that is going to get darker during pregnancy. That's the areola. And when we start talking about breastfeeding, it's going to be important that you understand this anatomy, because a lot of it in understanding the anatomy, it will help you to understand how to evaluate whether or not a baby is latching effectively for breastfeeding success. Pituitary and ovarian hormones greatly affect the development of breast tissue during pregnancy. Estrogen and progesterone during pregnancy are what actually stimulate that gland development, and it shifts from a mammary gland into more mammary gland development with very glandular tissue is actually going to be what replaces adipose tissue. Therefore, it's more an indication of success with milk production when we evaluate the change in breast shape and consistency during a pregnancy than evaluating what size they are to start with. You'll find that there are a lot of people in the community, unfortunately, that will come in thinking that they can't breastfeed because they're only an A cup, or they've never had big boobs, and so therefore they're never going to be able to be successful at breastfeeding. And so again, it becomes a big education piece. Breast size does not necessarily indicate success at breastfeeding or milk production. So, the female reproductive cycle. This is that dreaded menstrual cycle that, for some reason, females don't quite understand, and men hate to deal with. So, there are two main phases that we deal with in the female reproductive cycle. We have the follicular phase, which, if you think about that, breaks down into the phase pertaining to the follicle, right? Nice, simple way. What we see during this phase is the anterior lobe of the pituitary secretes what's called follicle-stimulating hormone. Well, what do you think that hormone does? It stimulates the follicles. So it stimulates the follicles within the ovary. What that does is it causes several different follicles to start to mature. And over the course of a couple of days, one follicle says, I'm the boss, all you guys, you're all suckers, and they all start to kind of shrink and go back to their resting state. And one of them claims dominance. And it's that mature follicle that then starts to secrete estrogen. Estrogen starts to thicken that endometrial lining, which we remember is which part of the uterine wall? Yep, the inner one. And it's those elevated estrogen levels that say, I got this, pituitary, you can slow down. We don't really need that follicle-stimulating hormone anymore. You stimulated me enough, I got to where I need to be. And what happens is that follicle-stimulating hormone drop-off now tells the pituitary to start producing what's called luteinizing hormone. And it releases it. That luteinizing hormone surge is what causes the egg to burst out of that ovary and say, I'm free. It's kind of the push it needs to get out of the nest. That luteinizing hormone now converts that ruptured follicle into what's called the corpus luteum. Yeah. So it does, and progesterone is going to come into play in just a second. What happens is that egg, now after that luteinizing hormone has been released, as it starts to travel down that fallopian tube, that luteinizing hormone keeps that corpus luteum open, and the corpus luteum is what secretes the progesterone. And what the progesterone does is it now takes over the responsibility of what the estrogen started, and it not only thickens the endometrial lining, but it gets it much more highly vascularized. It causes a vasodilation, and so now not only do we have this nice thick lining, but we also get this big supply of blood to that lining. Does that make sense? If the egg does not get fertilized, that corpus luteum starts to break down. And the estrogen and progesterone levels start to drop off, because that corpus luteum is what was secreting that estrogen and progesterone. So with that drop off of progesterone and estrogen, now we don't have anything that's supporting that nice endometrial lining, and so it sheds, and we get bleeding. Bleeding marks day one. We always think about it as like the end of the cycle, but it's actually the cycle all leading up to it, and bleeding marks the beginning of now the follicular phase. And we've started all over again. Does that make sense? See why we were talking about all that stuff and whether or not it all kind of computed? One of the biggest things that we see with infertility is that people will end up needing progesterone supplements through the first 12 weeks of the pregnancy. Because if that egg were to be fertilized, in theory, now that corpus luteum would stay open and continue to secrete estrogen and progesterone. That estrogen and progesterone keeps that lining nice and thick, gives that zygote somewhere to now attach and grow. If that lining doesn't stay nice and thick, even if that zygote implants, what happens? Miscarriage, and we get shedding of that lining. So we've found that by giving these women progesterone, it's that their corpus luteum is not effectively maintaining those levels until the point where the placenta can take over, which is at about the 12-week mark. And we're going to talk about that here in just a second.
So progesterone is given to help women get pregnant. Okay.
Or to stay pregnant, not to but to stay pregnant. If that's the problem that they're encountering.
I was on it for 90 days. 90 days after.
And part of that, some places will do it a little bit differently, and it may be that, like in your instance, that the corpus luteum was able to maintain a little bit, but not quite enough, and so yours kind of gave it the boost until the placenta could start to kind of supplement it itself. So it will vary. It's 12 to 15 weeks is kind of like the worst case scenario, because by then the placenta should be able to do it itself. But yeah, I mean, that's kind of the generic that you hear about in nursing school, but the reality of why OBs get paid the big bucks to make those decisions is that there's a whole lot more to it than the basics of what we're talking about. So, how do we get to the point? How do we get to the point of having a fertilized ovum? Well, we need a male. We can't do it alone. So for the male reproductive system, we've got two external structures, the penis and the scrotum, and internally we've got the testes, the epididymis, the vas deferens, and the ejaculatory duct. Those are the actual structures, and then there's three different glands that are also imperative. The seminal vesicles, the prostate gland, and then the bulbourethral or Cowper's glands. Those are kind of interchangeable terms that you'll hear or see. The penis itself is comprised of 3 columns of erectile tissue. The gland itself is the enlarged portion of spongy tissue that's at the end that forms a cap. And then the prepuce is the loosely fitting skin that covers the gland that we also know as what's called the foreskin. So during a circumcision, the prepuce is what's removed. The scrotum, if you guys remember, is related or correlated to the what in the female system? Labia majora. So the scrotum in men is going to be wrinkled. It's a pigmented pouch, and that's where the testes reside. We also have the epididymis in there, as well as a portion of the spermatic cord. And the spermatic cord is kind of a segment of the epididymis as well. Internally, we've got 2 testes. They are 2 oval-shaped glands that are within that sac that we talked about. Important for you guys to know these terms, because while we know the medical terms, a lot of lay people do not. It gets to be a very interesting discussion, and you need to figure out ways to hold a very grown-up conversation with terms that are not necessarily very grown-up when you're talking to people either about parts that they have themselves or parts that their children have. When a physician comes in to explain that their son has testicular torsion and explains it and then leaves, and the dad looks at you and goes, "What's a testy?" What do you say? How do you find a way to say that in a manner that you're comfortable with? I tried to beat around the bush, and ultimately what came out was, it's his nut. Because there was no other way around it. I mean, you have to work within the constraints and the confines of the culture that you're dealing with. And it may be that you have a 12-year-old that's got a kid. Or it may be that you've got somebody that doesn't have anything beyond an 8th grade education and never heard the term testy. Because his dad always called it a nut. So you have to find ways to make yourselves applicable to the population you're talking about. And there is nothing like maternal child nursing to make you realize how little people know about medical terminology. So again, important for you guys to know these structures and understand what the lay terms are as well. Although those I'm not going to teach you. So the testes themselves are composed of seminiferous tubules, which is where sperm and semen are produced. And unfortunately, you guys won't get to see this in like an A&P class. But when I was in nursing school, we got to dissect them and stuff, and they totally look like a bowl of ramen. It's crazy when you actually get to see what they look like inside. You'll never eat a bowl of ramen the same way ever again, but it's pretty cool, I thought. In between those tubules are going to be Leydig cells, and that's what's actually responsible for the production of testosterone. The epididymis is kind of the outflow track. It's what connects the testes to the vas deferens, and if you look on the slide, it's basically what goes from the testis itself up and over until we reach this kind of arch. It's the excretory duct, and it's where sperm will reside for up to 3 weeks while they're maturing and getting their motility organized and figuring out how to swim in a straight line and that sort of stuff. The vas deferens itself is going to be the connection where the epididymis goes past that seminal vesicle duct, so that duct that we were talking about, that accessory duct. It's also the site of a vasectomy. So if you look at it, it's basically where this vas deferens now comes down and connects into that urethral opening. So that's where they go through and do a vasectomy.
Yeah, vasectomy.
So the spermatic cord, I'm pretty sure, is down here at the bottom. But they're all kind of one connected tube. So the ejaculatory duct itself is going to be where that continuation of the vas deferens continues to go through until it hits that urethral connection. It's located at the base of that prostate gland. Yeah.
What is the part that they cut for the vasectomy?
So it's right here, kind of right at that arch. And if you think about it, you can see why they can do it in the outpatient setting. Because if this is the groin, it's right there. You know, it's a fairly easy procedure. They come out a little bit bruised afterwards, but that's about it. So the ejaculatory duct itself is located at the base of that prostate gland, which is going to be important because the prostate is a very integral part in making sure that the sperm have the ability to travel out of the male structure and into the vagina. And then that's where the actual location of the ejection of sperm and seminal fluid go into the urethra itself. So we've got the testes, the epididymis, the vas deferens, the ejaculatory duct. And then that's where it joins up with the urethra and comes out. All of these things have to be connected appropriately, and they have to be able to pick up the correct nourishment and fluid along the way. And that's where these accessory glands come into play. So you have the seminal vesicles, which are the sac-like structures that are at the base of the bladder, and they are producing the majority of the ejaculate. So you've got the sperm that are in the ejaculate, but this is the actual medium that they're transported in. The prostate gland itself is the structure that surrounds the urethra just below the bladder, and so for your patients that have like BPH, that benign prostatic hypertrophy that I'm sure you guys have learned about thus far, it's because that prostate gland is now putting pressure on that outflow tract. And it's on the urethra itself, so now it's not just a problem with ejaculation, it's also a problem with urination, which is typically the one that brings them to the doctor more readily, because most people don't really like to talk about problems with ejaculation. Urination comes a little bit more freely to discussion. So during ejaculation, the prostate gland actually contracts along with the vas deferens and seminal vesicles, because what that allows for is so that the semen, the sperm with the seminal fluid, it allows for it to go out the urethra rather than up into the bladder. So if you look at it as we're going by, we've got the vas deferens, it picks up that milky, thick secretion from the seminal vesicles, it comes down into this pink kind of like heart shape, is sort of like a bisected view of the prostate. This is actually surrounding that whole structure. So it's coming down, picking up that fluid, and now, in theory, it would go the path of least resistance. Well, it's a whole lot lower of a pressure system for it to go up and into the bladder. But if it contracts, if that prostate contracts down, now it has no choice but to come out the urethra. Cowper's glands are far smaller. They're the size of a pea, and they're on either side of the prostate gland, on either side of that urethra. And they're also going to secrete mucus into the urethra that serves as a lubricant and provides alkalinity. Now, why would it need alkalinity? Because the vagina is acidic. So it's sort of like the capsulated transport vessel that it's got that slowly dissipates as it's going up the vagina. It's kind of like if you think about the Apollo launches, and you think about the rocket going into space, and like the rocket shell itself kind of slowly breaks off and falls off as it's going through this extremely hot, burning atmosphere. Kind of the same principle of semen trying to get to the uterus. There's a reason they describe, medically, they describe the vagina as a hostile environment. And it's because it's not very nice to anything in there. It doesn't want anything in there, and it tries to keep everything out. You know, it's a protective mechanism to keep that area, that uterus, where they're going to create life to stay healthy. So everything that's got to go in there to create that process has to be protected. So, menstrual disorders. There's a couple of these that you have to know. Your text goes through quite a few more, but when we talk about this kind of stuff, this is where I was saying if this is the content we talked about in class, this is the content from the text that you need to know. They may cover 12 different disorders, but the ones that we talk about are the ones that you really need to know. So dysmenorrhea and amenorrhea. There's two different kinds, and you'll notice they're very similar sounding. Dysmenorrhea, by definition, is painful menstruation, whereas amenorrhea is the absence of menstruation. Kind of easy to remember with the A's, amenorrhea, absence. Dysmenorrhea, there's a couple of different causes. The four most common are going to be endometriosis, infection, stenosis, and fibroids. Symptoms that you see with these all have to do a lot with irregularities in hormone regulation. So headaches, backaches, chills, nausea and vomiting, fevers, kind of very vague symptoms, not things that necessarily tell you they're in pain. It is managed medically. We give NSAIDs to decrease the inflammation of that menstrual process. NSAIDs block progesterone, and so it tends to diminish the inflammatory effects. Heat application, we also educate them on pelvic exercises because exercise in general will increase endorphin production. Endorphins block pain sensation. So we get them exercising, not because it's a health benefit, but because it gets the pain to go away. Kind of an odd proposal, but a great technique. Endorphins also suppress prostaglandins, which is what NSAIDs suppress. So it's a non-medical, non-pharmacologic treatment that's free. And then in worst case scenarios, especially with endometriosis, we'll see a DNC, which stands for a dilatation and curettage. So they dilate the cervix and go in and basically scrape out the entire lining of the uterus. Imagine that's not the most comfortable of procedures. And then lastly, we educate them about avoiding fatigue. You know, during their menstrual cycles to maintain a low-key kind of rest, don't overstress themselves because fatigue can make pain seem worse. And then with amenorrhea, the absence of menstrual periods, there's two different kinds. There's primary, where they've never had a period by the time they're 17 years old, females, obviously. And secondary, which is the absence of a regular menstrual cycle for 3 cycles, or if they're having significant irregularity for 6 months, and this is in women that have previously menstruated regularly. So something has changed. Typically, the most common cause of amenorrhea is pregnancy. Because if they're pregnant, they're not going through a menstrual cycle. Diagnostics, things that we look for this are pelvic exams. Sometimes they'll look at luteinizing and follicle-stimulating hormone levels because if those are awry, you remember where those play that role. If we don't start the cycle appropriately, if we're not stimulating those follicles appropriately, or maybe we are, and it turns out that luteinizing hormone surge is never happening, menstruation is not going to happen. Things that we'll see in the secondary situation outside of pregnancy are going to be things like diabetes, obesity, anemia, if they're on birth control. You know, things that we don't necessarily think about, but may very well appear on a select all apply kind of a question. And then endocrine gland tumors, because the endocrine gland tumors are going to affect which major organ that's responsible for the menstrual cycle. Pituitary. So if you have somebody that's got pituitary tumors or they've got an issue with menstruation, it may be the first sign that we have that they've got a pituitary tumor. Again, not something that you necessarily associate with like women's maternal child health. It's something that you might see in your med-surg world, but it's a question that would tie the two in on your board. PMS. How many of you guys have heard of that? There is an official medical diagnosis definition for PMS, and it's a recurrent condition during the luteal phase that causes physical, psychological, and behavioral changes that interfere with interpersonal relationships and normal activity. They don't have a treatment for it. Novel concept. Typically, it's a multidimensional approach because there's not one singular cause where they can say this is why women have PMS. They advise for things like vitamin supplements, dietary changes, that aerobic exercise that we talked about earlier 3 times a week, making sure they're eating a balanced diet, helping them to maintain serotonin levels. Sometimes they've found that it's a drop in serotonin levels that have caused these PMS symptoms. So occasionally, if all else fails and they've tried all of these other lifestyle treatments and it's significant enough where it's truly interfering with their day-to-day life, they might consider putting them on a consistent or a continuous antidepressant therapy, like an SSRI. That begins to be a major issue when we've got people that are trying to get pregnant because SSRIs are big no-nos during pregnancy. Health promotion, medications, we've kind of talked a lot about that. I mean, SSRIs really are the big ones. There's not much else that they can do for PMS. They do, by definition, have to have at least a few affective and a few somatic symptoms. So if you look at the bottom, those are kind of the ones that they have to have for it to be PMS and not just somebody being grouchy. Depression, angry outbursts, extreme irritability, anxiety. Now, these are not things that they have every single day out of a 30-day period. These are things that are only appearing during that luteal phase of the menstrual cycle. So during the ovulation until menstruation portion of the menstrual cycle. Somatic symptoms, so physical symptoms, are going to be things like breast tenderness, abdominal bloating, edema, and headache. A lot of people claim PMS when really what they are is irritable, or grouchy, or tired, or hungry, or in nursing school. They're not necessarily PMS unless they fall into these categories. Although, I don't know that I would dare challenge somebody on that during that time frame. Endometriosis, as we just mentioned in one of the other slides for that dysmenorrhea. Endometriosis, by definition, is not really known why it happens. It's one of the most common gynecologic diseases, and what happens with endometriosis is part of that endometrial lining. There's endometrial tissue that is functional, but it's located outside of its normal location. So in theory, that endometrial tissue should just be on the endometrial lining of the uterus. But if you have somebody with endometriosis, that endometrial tissue has now been additionally displaced on the ovaries, fallopian tube, the rectum, the bowel, the bladder. It can be anywhere within that abdominal cavity. Well, during that menstrual cycle, what's happening to endometrial tissue? It's proliferating, it's getting nice and thick, right? Increasing in vascularity, and then it's shedding. It's going to do that anywhere that it's located. So you might have signs and symptoms like rectal bleeding. They might have blood in their urine. They might have blood in their stool. It's one of those things that in development, it's abnormally placed. It's not something that, it's like they're born that way. Correct. The two most common symptoms that we see are going to be pelvic pain, because you can imagine, as bad as menstrual cramps can be for women, now if they've got that tissue displaced elsewhere within the abdominal cavity, those abdominal cramps are going to be magnified that much more. And infertility. That's usually how endometriosis gets diagnosed, is somebody's been trying to conceive for a while and they haven't been able to, and they go in for an ultrasound to kind of see what's going on. Risk factors, higher age, family history of it. If they historically have very short menstrual cycles, so their menstrual cycles from start to finish are less than 28 days long, and or they've got a really long menstrual flow. So somebody who's bleeding for more than a week, but start to finish their whole cycle is less than 28 days. So they might be bleeding 1 week out of 3, and then all of a sudden it's starting all over again. High dietary fat consumption. If they're very young, when they first get their period, that menarche is the first time they get their period. If they're under 12, these are ages and numbers you have to just know, because they're kind of the standard on what's normal. And then if they've had few or no pregnancies. Oftentimes, if somebody has endometriosis and they can get pregnant, it doesn't really seem to be a problem thereafter, because the lining of that entire endometrium has shed, and it's almost like it starts fresh. Sometimes what they'll do for infertility situations is they'll actually go in and do a DNC, or they'll burn the lining of the uterus to cause it to shed more drastically than it would if it were just a regular menstrual cycle, and sometimes that seems to kind of reset things like a pregnancy would. Management in endometriosis is, the aim really is to suppress those levels of estrogen and progesterone that's causing that endometrium to proliferate and grow, because that's what's causing the pain. Where do we find estrogen and progesterone in medication? Birth control. So the management of endometriosis is birth control. That's like their frontline treatment, is to put somebody on oral contraceptive or depot. Sometimes they'll use synthetic testosterone, because testosterone will balance or counteract estrogen and progesterone. And then GnRH agonists are gonadotropin-releasing hormone agonists, because if we can, what GnRH is what the anterior pituitary secretes. So things like follicle-stimulating hormone. So if we're stopping that process, the estrogen and progesterone levels will also stay low. Now, what if you have somebody who's trying to get pregnant with endometriosis? What's your mainline treatment? Is it going to be oral contraceptive? No. That very much could be the kind of critical thinking question you're going to see on the board, because you've studied and studied and studied, and your mainline thought is oral contraceptives are my treatment of choice for somebody with endometriosis. My person in this has endometriosis, that's my answer. And you overlook they're pregnant, or they're trying to get pregnant. In those situations, we look at things like surgery. If it's prolonged infertility situations, they'll go in and do like a DNC or an ablation or something like that in order to kind of try to reset the cycle. Does that make sense? Fibroids. Fibroids are benign tumors that we see that are primarily composed of smooth muscle and connective tissue, and they grow within the uterus. Unlike cancer, fibroids typically grow very slowly, and the cells, the tumor cells, don't ever break away from the original tumor itself, and so they don't invade other parts of the body. They stay localized. They continue to grow, but they stay put. They don't metastasize. They don't go anywhere else. The things that we see with uterine fibroids are going to be menstrual disturbances, because you can imagine if there's something in that uterus, it's going to disrupt the normal operation of that cycle. Backache. Again, because if there's something growing within that abdominal cavity and it's putting forward pressure, now their back is going to hurt. Frequent urination. You remember that picture that I showed you about where that uterus is sitting? Well, if that uterus is filling, we don't know why. Maybe there's a fibroid in there. Maybe they're pregnant. If it's filling and it's growing, it's going to push forward and lean right on the bladder. So frequent urination is going to be fairly common. Constipation, because again, as it's growing, where's that rectum? It's right behind it. So as that fibroid is putting pressure on those external barriers of that uterus, It's now putting pressure on that bladder and the rectum, and their intestines might be completely functional, but if there's a big old blockage there, it's not going to make its way through. Uterine fibroids are estrogen dependent. Kind of an interesting uniqueness to them. So typically, because they are estrogen dependent, they grow much more rapidly during childbearing years, because that's when women have the highest levels of estrogen, because their body's going through those cycles very frequently trying to get pregnant. During menopause, estrogen levels drop off drastically, and now the fibroids tend to shrink. So we tend to see much more problems with uterine fibroids during childbearing years. Now, mind you, childbearing years range from like 15 to 40. We're not talking about just in the 20s. Peak incidence that we usually see is going to be around age 45. Treatment that we do for uterine fibroids are going to be those gonadotropin-releasing hormone agonists. So again, those agents that are going to suppress that estrogen cycle. So things that we see are things like Lupron, Cinerel, Zoladex. Those are kind of the three big gonadotropin-releasing hormone agonists that we see. We're not going to talk a ton about side effects, but you should be able to kind of think through it and say, if it's stopping that entire menstrual cycle, right, because we're stopping it at the follicle-stimulating hormone component, what side effects would you expect to see? Menopausal symptoms, because we're stopping that whole process. Now, they don't have estrogen. So because of those side effects and the fact that those meds are all very much name brands, if you look at how they sound, they're expensive. They don't have generics of them. So between the side effects and the cost, it makes compliance very difficult when it comes to pharmacology with them. Surgical removal then becomes the next option. Usually they'll do a myomectomy, and if you remember, the myometrium was that middle layer. So they'll actually go in and take out the entire middle layer of that uterine cavity. If somebody is still of childbearing age and wants to have children, do you think that that's a viable option? No. Laser surgery and then an abdominal hysterectomy would be the last kind of step. With myomectomies, it's hard because oftentimes if they don't get enough of that uterine fibroid, it can grow back. So it's one of those, they've got to get all of it, otherwise it has the potential.
Are these what people call uterine cysts?
I don't know that I've actually heard that term. Are you thinking of like ovarian cysts?
No.
Ovarian cysts are when that maturing follicle, oftentimes it's not just one follicle. Several will try to mature, and a couple of them don't do so effectively, and they collect with fluid instead of maturing appropriately. And that's probably more like what you're thinking. It can, if the UTI gets bad enough. With pregnancies, especially because of the close proximity between the bladder and the uterus itself, you worry if the UTI isn't caught early enough, a lot of times it'll cause uterine irritability, and it'll cause the uterus to contract. Pelvic organ prolapse. I'm basically going to get through these kind of pelvic scenarios, and then we'll take our break. So pelvic organ prolapse is, by definition, an abnormal descent or herniation of the pelvic organs from their original attachment sites. There's probably good pictures of this, I think, if I remember right, in your text. Basically what happens is the structures of the pelvis shift, and they protrude either into the actual vaginal canal or outside completely. So a cystocele, for example, is a bladder prolapse. And it may be that the bladder, rather than staying where it's supposed to, now falls into the vaginal wall. Things that will see this are going to be like on a vaginal exam. You may actually see a protrusion into the vagina. They may end up with pain during intercourse. They might have urinary frequency. You can imagine if that bladder is displaced from where it should be, it's not going to empty appropriately. A rectocele is where that rectum is now prolapsed, and it can either prolapse anterior and prolapse into that vaginal wall, or it can prolapse entirely and actually prolapse out of the body. I've actually seen a complete rectocele where it's a rectal prolapse, and it's kind of crazy. It's like very, very, very pink. but the whole organ literally inverts on itself and comes out of the body. And their treatment for that seems extremely barbaric, but the surgeon basically rushed in. They covered it in sterile gauze, because you always want to keep internal organs sterile regardless of where they are. And the surgeon came in and basically grabbed it and shoved it back up, and they went to surgery to put in a sling to kind of keep it where it's supposed to be. So ideally, we would like to prevent these if we can, you can imagine. An enterocele is where the intestines are now prolapsed or displaced. And then a uterine prolapse is where that uterus is either displaced downward into that vagina and putting pressure, or it actually inverts and prolapses out of the vaginal canal as well. Kegel exercises, these are huge. I can't stress enough when it comes to health promotion for adults, older women especially. Kegel exercises are kind of like the staples that we go for because they're free and they're cheap, or they're easy and they're simple. It just boils down to education. And it's a lot about teaching them to do them when they're, a lot of people are like, well, I don't have time for exercise, but it's stuff that they can do when they're up and about. When you're at a stoplight, try to squeeze the muscles that you would to stop and start a stream of urine. Those are the muscles that we're talking about. It's the pelvic floor muscles. Have them do that 5 times at every stoplight. It's the muscles that they stop and start when they've got to go poop. Like when you really got to poo really badly and you're holding it as tight as you can and you're running to the bathroom, it's that muscle. You all know what I'm talking about because you're laughing. Everybody should be doing them. These are the things that we need to educate people of childbearing age on because prevention is key. Those are the exercises that prevent things like pelvic organ prolapse. The other thing that we can do is hormone replacement therapy. However, before we ever do hormone replacement therapy with estrogen, is we need to evaluate their health history for risks of complications. So anybody that's had endometrial cancer, heart attacks, strokes, breast cancer, basically anybody that would not qualify for birth control pills does not qualify for hormone replacement therapy. Dietary and lifestyle management modifications, vaginal pessaries, this one's kind of a hard concept to understand, and so I encourage you to look back at your book for visual diagrams of it. But basically a vaginal pessary is a ring that goes up the vagina and puts pressure wherever it's being prolapsed on. So if you have like a rectal prolapse that's pushing on the vaginal wall and is bulging through, that vaginal pessary will go up and kind of open and stay open and put the counter pressure against it so that it goes back into place where it should be. The hard part of that is now you have a plastic or a metal ring, whatever it may be, ring internally on tissue putting pressure. What do we worry about when things stay in place and we don't move them? Sores. So there's a lot of education that goes into educating about how often they can be left in, how often they need to be changed, that sort of stuff. And then surgical interventions with pelvic organ prolapse. Education beforehand is very important. They all come back out with a Foley catheter that stays in place for up to a week at home that they need to learn to manage. And then they need to avoid any kind of activities that increase abdominal pressure. So we give them stool softeners because we don't want them bearing down to poop. And pelvic rest for 6 weeks. How many of you guys know what pelvic rest means? Go for it.
Oh, no sex.
That's what most people think.
Oh.
You're on the right track. No sex is number 1. No nothing in the pelvic area. No fingers, no toys, no tampons, no nothing. And you have to delineate all of that because most people, when you say pelvic rest, take it to mean no sex. You would be amazed at what people come back in with because they were not educated properly. So you're not alone, and I appreciate the...
Other people do I assume that meant anything down in that area, but other people have other mental states about that?
If it's not educated to them, you can imagine the things that you see in the medical field. You learn that you need to be very explicit on your instructions.
So the prolapse, are you more likely to have something like that after childbirth?
Mm-hmm.
Okay. So
Or the other place that we'll see it is like heavy weightlifters.
oh.
We'll see that there's like a ton of really disturbing videos on YouTube of guys weightlifting and they have a rectal prolapse.
Yeah.
Mm-hmm.
Yeah.
Why don't you guys go take like 10 minutes or so and then we'll sort of jump in and get to as far as we can. Yeah.
For test,
Yes.
test 1 is going to be over chapters 3 to 10.
Theoretically, yeah. I haven't made you name it because I like to see exactly how far we get. So it'll be basically whatever we start on or whatever we get to at the end.
Okay. And I have, would you recommend making sure the book that you don't have to read every page? Would you be able to get PowerPoint before class?
Not necessarily before class. I mean, you could.
I'm going to, but
A lot of it is going to boil down to time management. This part, because I don't know what you're like out here. So if you find that you're not going to have a lot of time after, like between my classes and time with my class rolls around, so my best is how to read the PowerPoint slide we're in, and then go back and jot stuff down from the text after. In the or you can use like the heading on the PowerPoint and really go to it. This is kind of important. That helps.
I wish I
There's
wanted to work.
what your schedule is like, you know, because there's a lot of it's nice in this 10-week period because you actually have more class hours, so we're able to cover more stuff more effectively than the 3 weeks. Does that help a little bit? I mean, when the other thing that I will do before the exam is I put a study guide. That when I create the exams, what I do is like I'll create a question and pick out the topic that that question's on and put it on the study and like directly so that it will help to focus your studying. But I will tell you the study guides are usually like 2 to 2.5 pages long. So content, so it's not like.
And you'll release that study guide like
Sometime, so this class is on Thursday, and ideally I would say before the end of the week. I don't know how I want to do it. Like I work every other weekend, Friday to Monday night, so it's just sort of on when I get the time to do it. But usually I should have the study guide up to the day. Right. More than one day. Yeah. Yeah. So you should have, you know, 4 or 5 days or something. I try to get it up as quickly as I can because I know there's an overwhelming volume of material. So I do feel for you guys. I mean, it's a lot, but the study guides really are. They should be fairly helpful. I mean, I don't go into significant depth, so it might be that it says, you know, genetics, and that might be as much information as you get on where to focus your attention, but you can guarantee that there's at least a question or two that are going to be specific about kind of what we talked about with genetics. Or when we start looking at more of like these disease processes, it'll be like, you know, it might include something and just say endometriosis. I'm not going to tell you the nursing care and endometriosis or the treatment of it or whatever, but at least it'll help you to focus so that you're not sitting here looking for 12 menstrual disorders that we covered in class, saying which of these do I need to know. So it'll help narrow it a little bit. Not a ton, but better than having 1,000 pages to read through and figure out where the important parts are. The quizzes will also help, I think, once you get a little bit more familiar with them, because they force you to study every time. Yeah. We'll just kind of wait for everybody to sort of get the majority of you guys back in, and we'll get going.
Hey, geez,
You know that feeling at like the movie theater?
Well, I won't take personal offense. You did that.
Nothing to do with you. It's just more like, I like the second row is perfect because then you're like posting up. Actually,
So has this been tolerable so far? You guys aren't totally pained?
it's good. It's just I already knew it was gonna be a lot to take in.
Yeah.
Because how short the semester is. So
It's a lot.
our bio class is like that because it's like like accelerated. Yeah, they changed it because they don't do AP wanted but they made it like crazy bio.
Yeah, it's a lot. I mean, it'd be one thing if I could do it without all of like this stuff, but you don't get this anywhere else. So it's like, oh.
Is there a reason why they didn't do like why they gave you a 4-hour block and not do like?
A lot of it had to do with scheduling.
Oh.
Yeah. Kind of rearranging and whatnot. And honestly, you guys actually get more class hours over the 10 weeks doing it this way than the class does as a 2-hour block over the 16 weeks. So, yeah. So actually, like when I was arranging these, till the fall. In which case, you guys have class in fall? Or are you done? You're done at the end of this, right? Oh my goodness. That seems insane. Alrighty, we're gonna get jump started. So fibrocystic breast changes. We're getting close to the end of this kind of content before we dive into what we start to see with actual pregnancy. Fibrocystic breast changes, though, we do see a fair amount in people of childbearing age. Usually we see it the most between ages 20 to 50. And it's what we see as a response of breast tissue to monthly estrogen and progesterone levels. So it swings, and so the actual fibrocystic breast changes that you'll assess will shift depending on the time in their cycle, in their menstrual cycle. It's very rare in postmenopausal women. Why? Right, because they have low estrogen and progesterone levels. So if it's happening as a response to the breast tissue being exposed to those levels, postmenopausal women is fairly uncommon. That should help you to not have to memorize like the age ranges for these kind of things if you can sort of think it through a little bit. Nursing assessment-wise, we will notice that they have lumpy or tender breasts. Typically it's bilaterally, and it happens primarily in the week prior to menstruation, because that's when we have the highest levels of estrogen and progesterone, right? During that luteal phase, as the body's trying to prepare for pregnancy. When menstruation happens, pregnancy obviously didn't happen, and now those levels drop off. So we're going to see the symptoms the most during that week prior, during that luteal phase. Oftentimes they'll complain of dull, aching fullness. They can have a clear or a yellow nipple discharge. Typically what we see is like a fibrosis or a thickening fairly early on. And as it develops and continues to get worse, sometimes they'll end up with cysts that form as a result, of that fibrosis. And the cysts, and this is important, the cysts are usually mobile, they are tender, and there is no skin retraction associated with them. Sometimes they'll feel like a little pea or like those little pearl onions, a fairly small size nodule, and it moves. And it hurts if you push on it. There's no nipple, there's no skin retraction. So there's no like dimpling because it's mobile. You get that skin retraction when there's a pressure being put on the internal side of the tissue holding it in a firm location. Those are important because those are going to be your key indicators that it is likely not cancerous. Mammography and ultrasound are the ways that they diagnose it. Ultrasound can be kind of hard because it can be hard to localize it since it is mobile. But oftentimes they will try an ultrasound first because it's less painful, less stressful on the patient. Education about the condition is important as far as our management goes. Self-care tips, making sure they're still doing monthly breast self-exams after their menses. That's important because if they're doing them before they menstruate, odds are they're going to pick up these benign masses. So it's important that when they're doing breast self-exams, universally for women in general, that they're done after menstruation has started. Therapeutic management, we want to limit things like methylxanthine, so anything with caffeine in it. Caffeine makes it worse. Aspiration they can do with a biopsy if they're still concerned that it might be malignant. So if they go to do the ultrasound, they're not still 100% sure what it is, the next step would be to then look at it and do a biopsy to make sure. And then they can give medications for severe cases. What kind of medications do you think that we would be looking at? We're going to be looking at things like birth control or those gonadotropin-releasing hormone agonists like we were talking about before. Do you guys have any questions about those?
I have a question about the nursing assessment, the
Yep.
lumpy tender breast. Are we doing breast assessments? Because I'm like, you earlier, whatever, I've never had a nurse actually do that. It's always been the provider.
Right, and it usually is the provider, but per your boards, you do them.
Oh.
Yeah, I honestly don't know that I've ever seen a nurse actually doing it, but a lot of it boils down to making sure that you know how to, so you can educate them on how to do it at home. A lot of it depends, too, on what kind of a setting you're in. You may find that, like at Planned Parenthood, that it may be a nurse that's actually doing the assessment because they're not necessarily coming in and seeing a physician for the full assessment.
You said it's usually caused by high levels of which hormone?
Progesterone. Yep.
And you said the medication was birth control.
And those gonadotropin-releasing hormone agonists, those are usually the ones that you see, just because they limit that whole process. But those they usually reserve for pretty severe cases, so for people that are having significant pain, that it's really bothering, because they're benign. They're not something that gets worse. They're not something that necessarily progresses to something cancerous. They're not. They're something that go away with time, like as they get older and those estrogen and progesterone levels decline. That's why they're not going to go in and surgically remove them, typically. With breast cancer, now we're talking about an actual neoplastic disease where regular, normal body cells are transformed into cancers. Breast cancer is the most common cancer in women, and it's the second leading cause of cancer death in American women. If you start looking at statistics outside of the United States, they deviate a little bit, but for our purposes, it's the leading cause of cancer, and it's the second most, with the highest mortality. So what we see with breast cancer, pathophysiology-wise, how does it happen? What happens is we have the epithelial cells that are within the mammary duct within the breast tissue. So the ducts that are actually responsible for milk production. Growth rate of breast cancer is very hormonally dependent, and so it's influenced very drastically by estrogen and progesterone, which is why people that get diagnosed really young, it's so much higher of a mortality rate, because it's a much more aggressive cancer because they're hormonally dependent. And hormones are much higher in a younger woman than a postmenopausal woman when we're looking at estrogen and progesterone. Non-invasive breast cancer, the other term that you'll hear is in situ. So in sight, it hasn't left its initial location. They have not extended beyond their duct, lobe, or point of origin. For invasive cancers, and that doesn't mean that a cancer that starts out in situ can't become invasive. It has to do with when it's diagnosed. An invasive breast cancer has now extended into the tissue outside of that initial lobe or duct or point of origin, and it has the potential to metastasize system-wide. So when we're talking about cancers, invasive ductal carcinoma is the most common. So if you think about the definition of that name, carcinoma means cancer, ductal means it's in that mammary duct within the breast tissue, and it's invasive, which means it's aggressive and it has the likelihood to spread and metastasize. If it's non-invasive, it's not going to do that. So the actual word, the actual diagnosis tells you a lot about what you're looking at. Signs and symptoms for breast cancer: non-tender nodule, complete counter opposite of what we just talked about with those fibrocystic changes, right? An enlarged axillary node, because now it has the potential that it could be within the lymph system within that armpit that's local to where the actual cancer is. Nipple retraction or elevation, so if there's an alteration in one nipple to the other, so if the nipple is like pinched in or it's elevated more so than the other one, it has to do with where the actual tumor is located. So if it's directly underneath the nipple when it's pushing on it, it might extend, but if it's off to the side, it might kind of pull it, which will cause it to retract. Skin dimpling, same kind of concept. It's basically pulling the skin internally from wherever it is. You know, if this is the tumor and it's attached on the inside, and it's gonna going the other way, and it's gonna pull. You're gonna get this kind of an effect, and so it's gonna dimple, you know, wherever it's kind of pinching to, because it's gonna pull the skin to it from the inside. Nipple discharge, which again we can see with the fibrocystic changes, but most breast cancers present with little or no symptoms, which is scary. Again, why we educate people on breast awareness and breast self-exams. So the big ones that differentiate breast cancer from fibrocystic breast changes: breast cancer is not tender, it is not mobile, so it's creating that dimpling, and it oftentimes presents with little or no symptoms. Those are kind of your three big distinct differences between breast cancer and something that's more benign. Treatment for breast cancer, there's a couple of different kinds. They can do breast-conserving oral lumpectomy if it's caught early enough. A simple mastectomy, which is where they take the breast tissue, but the axillary nodes and the muscle tissue is actually preserved. And then a modified radical mastectomy is where they take the entire tissue, and those are the ones that are more conducive to reconstruction, because they basically are starting from scratch. Radiation therapy, oftentimes they'll do that with the lumpectomy to make sure that they're getting rid of any kind of microscopic cancer cells so that we don't end up with a recurrence. With radiation, we worry, and this again isn't really specific to breast cancer, it's cancers in general. So we're looking at things like inflammation, local edema, anorexia, sunburn-like changes because radiation is creating a burn effect, and fatigue because it tends to affect the red blood cells and the white blood cells, and so it drops their energy levels. Systemic treatments, we're looking at things like chemotherapy. Basically, those affect every single kind of rapidly dividing cell within the body. That's what we're going after when we're going after cancers or rapidly multiplying cells, because that, by definition, is what cancer is. However, it has a side effect that it eradicates everything that is rapidly multiplying. So we're looking at things like skin cells, hair cells, the mucosal lining of the mouth, which is why we see all of those sores that they get in their mouths, in the GI tract, bone marrow, all of those things. It suppresses all of that. So all of the side effects that we see with chemotherapy are going to be related to those systems. What would be something else that would be consistent with a rapidly multiplying cell that we might be talking about this semester? Pregnancy. How do you deal with somebody that gets diagnosed with breast cancer in the middle of a pregnancy? They can't very well do chemo. There's a good chance they probably can't do radiation. You know, you have to start kind of getting creative, and you talk a lot about priorities and educating families. I mean, that's where it becomes very important. Everybody looks at maternity and child health as like this happy-go-lucky field because everything goes well. And I will tell you, by the end of the semester, you will realize that it's not something to be taken lightly by any means, and whether it's from the nursing perspective or as a patient. Some of the things that we're starting to see more and more of a resurgence with now is the endocrine therapy concept. So they'll actually look and see what type of cells, what they're more susceptible to, what they're more sensitive to, whether it's estrogen or progesterone, and what they can give them as a result to kind of modulate those hormones to suppress the growth of the cancer. It's usually more like a management kind of process. Side effects that you'll see with this are hot flashes, bone pain, fatigue, dyspnea, headaches, not benign side effects by any means, and it basically is mimicking menopause. You look at the things that it's blocking: luteinizing hormone releasing hormones. We're looking at estrogen receptor downregulators, so it's going to downregulate the sensitivity of that particular cancer to estrogen. Progestin, things like that. I've got a really good girlfriend of mine who got diagnosed with breast cancer at 32. Stage 4, overwhelming, like really bad breast cancer. She got diagnosed because it was in her abdominal cavity, putting pressure on her hips, and it was in her bones, on her spinal cord. I mean, she's got a horrible prognosis. And they initially had given her 3 months to live, and she's now a year and a half out, and they're not ever planning on her getting into remission, but they're giving her a life of stasis. And the way they're doing that is with things like endocrine and immunotherapy, where they're basically giving her her body the ability to fight enough to shrink the tumors and keep them where they're at, because they can't ever go in and do surgery, because the second they open her up, they're afraid that it'll just stimulate massive growth, and that would be the end. So there are a lot of these kind of therapies that are coming out to help people live with cancer rather than die from cancer. Immunotherapies, those are the ones where they basically are trying to get the human body to recognize the cancer cells and to fight it themselves to help support that system, so that we're not necessarily going in and eradicating everything that they've got in the hopes of getting rid of the cancer cells. As a result, and kind of that example that I gave you is sort of a good example or a summary of the overriding decision for treatment choice. You know, we're looking at the types of cancer, the size, the grade, whether or not the lymph nodes are involved, whether or not it's metastasized, what its hormone receptor status is, and then genetic testing as well. You know, they'll look at all of that kind of stuff to help decide how they're going to proceed when it comes to breast cancer. And they're starting to look at this kind of stuff for cancers in general, not just breast cancer. They just happen to have a lot of evidence out there for it. Pre- and post-op care is going to be a lot the same as what you guys have seen in your other classes, I would hope. Witnessing informed consent. Do we obtain informed consent as nurses? No, never. We witness informed consent. You can be the second to sign, but you are not the one obtaining it. Ensuring that they are understanding, because if you are witnessing that informed consent, you are agreeing that they understand what they are signing. Important things for you guys to be aware of, because that's your license that you're now putting on the line saying they understand. If they don't understand, making sure that you're getting them information if necessary. You are more than welcome to educate these patients. You are more than welcome to provide them with information, as long as you are not the one officially obtaining that consent, saying, I educated them on all of these things. Vital signs and a physical assessment. Immediately post-op, what is your number one concern? It's always your respiratory. On any patient coming back from the OR, respiratory is always your focus, regardless of what kind of surgery it is. Respiratory is going to be your first step, then circulation, your vital signs, your skin color, all of that kind of stuff. Pain management. When we're talking about people that have had breast cancer surgery, we want to make sure that we are doing active range of motions and arm exercises with them as per orders. They may have some limitations, but as long as the orders say it's okay, they need to be mobilizing their arms. Encouraging them to do self-care activities. You want to give them their confidence back. You want to give them their sense of self back. Dressing and drainage care is going to be important, because oftentimes these people go home with JP drains for a bit of time before they come back for a final evaluation. With breast cancer, to minimize lymphedema, we want to make sure that the arm on the side that the breast was removed from is elevated. We always want that side elevated, because oftentimes when they take the breast tissue, they're taking axillary lymph nodes as well. Lymph nodes help with lymph drainage and return to the circulatory system. We don't have those lymph nodes. This arm now has no ability to return that lymph fluid to the body with any other ability than gravity. Gravity is their only help at that point. So you always want to make sure that they've got that arm elevated. Avoiding using the affected arm for drawing blood, IV access, blood pressure cuffs. Again, because of the constraints and any kind of restrictions on that arm, you're going to increase the risks of having that lymphedema happen. We want to make sure that they're wearing gloves when they're engaging in any kind of activity that might cause injury, because they are at such a high increased risk for infection. And they want to make sure that they're wearing well-fitted compression sleeves to promote drainage return, but not wearing constricted clothing. The compression sleeves are designed specifically for people that are having problems with lymphedema, and so it creates a snug fit that provides a graduated compression that brings the fluid back up. If they're wearing a shirt with constricted sleeves, what now happens to the rest of that extremity? All of that fluid pools and it can't come back. Just like putting a tourniquet on. If you left that on, that arm's going to lose circulation. It's the same kind of concept, because they don't have the ability to get that backflow return. So fitted compression sleeves are appropriate, something to encourage. Tight-fitting clothing is not. Education, we really want to talk to them about signs and symptoms of what they should be seeing, and then signs and symptoms to report. And the biggest one on that is going to be signs and symptoms for infection. And I don't think I need to go over that kind of stuff with you guys, right? Okay. Cervical cancer is going to be cancer of the uterine cervix itself. What's the number one cause of cervical cancer? HPV. I'm not going to go into this a ton with you guys, because it is something that's fairly well educated about in the population. Mortality rate in general for cervical cancer has decreased substantially because of the Papa-Nicolau test, that Pap screen. And the current recommendations, although these change all the time, but for your board purposes, the current recommendations are that screening is done every 2 years between the ages of 21 and 29, and then every 3 years if they're over 30 years of age. If you were to look this up on the website, the ACOG website, that's not what the recommendations are. They've changed. They've changed and extended it out, because what they've found is that there's basically a window of time where you're going to catch cervical cancer, and it needs to be treated immediately. But it grows really slowly in the other period of time. So it's either growing really, really slowly or really rapidly. And that really slow growth period of time is actually a lot longer. It's more like 3 years, 3 to 5 years. And so they've extended the screening rate so that it's still within that window of long growth, but will likely catch it at the rapid growth point in time. Does that make sense? That's sort of why you're seeing this shift in screening, although I guarantee you in 5 years it will change all over again. But what they're finding is that with these very frequent screenings is they're treating stuff that doesn't necessarily need to be treated, and people are getting colposcopies, which is where they shave off a layer of the cervix to get rid of any kind of abnormal tissue. And people are coming in with incompetent cervixes when they're trying to get pregnant and stay pregnant, and they're going into preterm labor or having miscarriages after miscarriages after miscarriages because their cervix is now so shortened it can't hold a baby in. So that may be part of why the recommendations are changing, but again, it's one of those that I'm sure we'll see shift in the next 5 to 10 years. There's a specific region on the cervix that we tend to see cervical cancer develop. It's on that squamous columnar junction. So it's basically because you've got this junction of two different types of cells that's called the transformation zone because there's a high potential for mutation. Whenever you've got two types of cells very close together where they're replicating, it makes it very easy for one to kind of get confused with the other and sort of go awry. And so that's why you see it in that particular area. Abnormal vaginal bleeding is usually one of the first signs that we see. Vaginal discomfort, post-menopausal bleeding. Anytime you have a woman that has bleeding after menopause, it's a cause for concern. That should be a huge red flag for you guys. But it may be symptomatic. Treatment typically, like I said, that colposcopy is where they'll go in and do a microscopic exam of that lower region and get rid of the material that they consider to be abnormal. Because they're trying to destroy any abnormal cells before they mutate. Menopausal transition, you'll hear in the community, people use the term, well, I'm going through menopause, and they're really not, because they're still having a period. Irregularly, but they're still having one. Menopause, by definition, is the naturally occurring cessation of regular menstrual cycles that lasts more than a year. So they have gone more than a year without a menstrual cycle. Then they might have one, and then it would be another year before they have a menstrual cycle. People will, well, it's been like 3 months, then they get it. And that's what's called the perimenopausal period, and that can take anywhere from 2 to 8 years before they're actually in menopause. So you'll hear that term thrown around, but there is a very distinct definition that goes along with it, and people use it incorrectly. With menopause, the average age is 50 to 51 years. Although that age is shifting, it is slowly getting a little bit older, and I think they're starting to attribute a lot of that to the prolonged use of birth control pills because people aren't ovulating, and then all of a sudden now they're 30 and just starting to ovulate where they should have been at 21, and so now we've kind of shifted that age. It's marked by an atrophy of the breast tissue, the uterus, the fallopian tubes, and the ovaries because of a lack of estrogen. Our assessment really boils down to screening them for osteoporosis, cardiovascular disease, cancer risks, talking to them about lifestyle management to prevent any kind of chronic conditions, and that goes back to that preventative slide that we talked about at the very beginning of class. Healthy eating, exercise, all that kind of stuff. Lifestyle modifications with this, it gets to be very important that they're doing weight-bearing exercises, not just aerobic exercises. And then hormone replacement therapy, although it is still pretty controversial because of the elevated risk of cancers that are associated with it, as well as stroke. If their symptoms are significant enough, and it's usually the symptoms that are associated with temperature instability and like hot flashes and irritability, things like that, that it does get started for. On the right side of the screen, it kind of goes through all of the symptoms that you see, and really they all boil down to a hormonal imbalance. I mean, that's where you're seeing things like hot flashes, memory problems. With cardiac situations, they actually have lower levels of the good lipoproteins. So they're at an elevated risk of cardiovascular disease. We're looking at a loss in bone density. We're talking about less calcium is absorbed because of their GI tracts being less effective, so we have an increased risk for fractures, and that's where the lower bone density comes from. All important for you guys to know as far as symptoms go. This is that preventative healthcare screen slide that I had mentioned earlier. It's just repeated again here so you guys didn't have to flip back 40 slides to find it. STDs. Hopefully these won't take us too terribly long to go through. This poses a huge impact on our health system. We're looking at $18 billion annually for the treatment of STDs. 65 million people live with an incurable STD, and another 19 million are infected every single year. Those are astronomical numbers when you look at that. This tells me that we are failing in our health promotion when it comes to STDs. There's a lot of things that go into it that people don't necessarily think about. You know, they get an STD that can be cured with an antibiotic. Well, it's no big deal. So they go in, they get a shot, the antibiotic, whatever, it's done. But the problem is they don't realize that there are long-standing complications that can go along with repeated STD exposure. We're talking about things like cervical cancer, infertility, ectopic pregnancies, because those STDs can cause scarring of the uterine lining. They can cause scarring of the fallopian tubes, chronic pelvic pain, death, depending on which ones we're talking about. And some can be transmitted in utero to the child. I've seen this on numerous occasions. We give antibiotics to every baby in their eyes to prevent any kind of an infection transmission. There's a lot of risk factors that go into it. There are certain cultural groups that are at a higher risk. There's some biological and social and behavioral factors that play into it when we start talking about teens. When we get to the pediatric component of the course, you'll totally understand why when we start looking at the developmental levels and what we're seeing at the teenage time frame. You know, they feel like they're invincible. They don't worry about unprotected intercourse as much. Their partnerships tend to be much shorter in duration. Most 12-year-olds are not in a 5-year relationship. And then obstacles to using the healthcare system. There are certain rules and regulations that make it really difficult, and they're state by state. In the state of Montana, you can go as a minor to Planned Parenthood and get birth control. You can get an IUD. You can get STD treatment. You can get all of that stuff without parental consent, without parental information, because they don't want the healthcare system to be a barrier. They don't want kids to feel like they have to talk to their parents in order to get treatment. Because what happens then is they don't get treatment. It's not that they go the proper channel, they just don't go the channel at all. And so that's part of our problem. Not every state is like that. There's a lot of southern states that will not sign on. A lot of the Bible Belt conservative states is kind of a big topic right now because of the controversy that goes along with it, because they're also making very adult decisions. It would be very hard as a parent to not know that your 14-year-old has an IUD. There's a lot of complications that can go along with an IUD, and if you don't know what to look for because you don't know that they have it, there's the flip side of the coin. I mean, there's a lot of arguments to both sides of it, but when we start looking at the actual treatment of STDs, it has gotten to become a big player. And then Table B3.2 is going to talk to you a lot more about sexually transmitted infections. It'll go into a lot of detail for you and kind of clarify a lot of this stuff, because there's a ton of information on these slides. Table B3.3 also goes into a bunch as well. Vaginitis, by definition, is going to be, it's the inflammation and infection of the vagina. And there's 3 different types of vaginitis. There's candidiasis, which is a yeast infection, trichomonas, and Gardnerella. Trichomonas is a protozoan, and Gardnerella is a bacterial infection, so that one's typically the easiest one to treat. The nursing role really boils down to making sure we're doing a very thorough assessment. We want to look at the risk factors, things like pregnancy, if they're on high estrogen birth control, if they've had high intensity or broad spectrum antibiotics recently, because then now that'll wipe out their normal flora. Obesity and HIV infections. Obesity, we look at it, most people don't think about this one, but what do we typically see in people that are obese when we look at lab values? elevation in blood sugar. What do bacteria and yeast love? Sugar. So when you have conditions that set them up for potential growth, now you've got somebody with obesity, their circulating blood sugar levels are going to be higher, the blood sugars within their tissues are going to be higher, it sets them up for an infection risk. We want to make sure to educate them about avoiding sex with any partners until everybody involved has been treated, whether or not they're symptomatic. Candidiasis, by definition, is the one that we see where it's an overgrowth of the Candida fungus, which again is part of the normal flora. With candidiasis, we see a thick, white, curd-like discharge with some itching, usually internally. They'll come in complaining of vaginal soreness or pain during intercourse, burning with urination. And the treatment is fairly simple. It's going to be one of the zoles, basically miconazole, clotrimazole, turconazole, or fluconazole. And some of those you can get over the counter, some of them you can't, depending on the strength. And they're a cream. They do have ones like diflucan that they can take, which is an oral pill as well. Trichomoniasis, men are asymptomatic carriers. So again, why it's important to treat them, because otherwise you get a patient who keeps coming back recurrently with a trichomoniasis infection, and they're getting it from the same partner, except for the problem is the partner never got treated because he's not symptomatic, he's not sick. So in women, they get a heavy yellow, sometimes a gray, frothy discharge. It's not thick, it is very frothy, like foamy. Again, that same itching, that soreness, a foul odor, pain on urination. And those patients, the only way to treat it is going to be with flagyl or Inclomaz. Flagyl is the bigger one that I've seen prescribed for that. And then bacterial vaginosis, you'll hear it on the TV, they call it BV. Gardnerella is the other term. That's the actual bacteria that is causing it. And it's the most common cause of a vaginal scent or malodor. And everybody always laughs at this, but what you get, the way they diagnose it is with what's called a positive whiff test. And it's not that they're whiffing the discharge. It's that they take a sample of that discharge and they mix it with potassium hydroxide, and when they do that, it smells fishy, like bad fish. I mean, you don't ever forget the smell. It's disgusting. But that's the official, that's diagnostic. So a positive whiff test. Don't go in there and they also will be accompanied with a thin white discharge, and again, with this, they're going to get flagyl, but sometimes they'll do clindamycin, just depending on the strain. So when we look at those were the ones that were characterized by discharge, and now we're going to talk about the ones that are related to cervicitis, or an inflammation of the cervix. Chlamydia and gonorrhea are going to be our top two. Chlamydia is number one, gonorrhea is a close second. Chlamydia can be hard because it's asymptomatic. It can be asymptomatic in both men and women, but usually it's more asymptomatic in women. Men will come in because they get a urethritis, or a redness and inflammation of the urethra. Female symptoms, really, they can end up with an ectopic pregnancy, pelvic inflammatory disease if it's left untreated for extended periods of time, and then infertility if it's been significant enough or a recurrent enough infection. Treatment is going to be antibiotics. It's typically penicillin. If they can't take penicillins, it'll be tetracycline. It's usually a big old penicillin injection in the butt. It's with a big needle. It makes them think twice sometimes about recontracting it. Oh, so salpingitis is an inflammation of the fallopian. Again, not something that comes with it a ton of symptoms. It's usually just a vague abdominal pain. But good question. Nursing-wise, our role is going to be to assess the health history, making sure we're evaluating risk factors, talking to them about symptoms, and ways to prevent it in the future. How do we prevent chlamydia infection? Condom. No, that is a great thought. Actually, you bring up a really good point, and this becomes important when we start talking about contraception. When it comes to your board, it's probably one of the few things that they're actually very realistic about. when we talk about contraception and they ask you to recommend a form of contraception to a 16-year-old girl that just delivered her first child that doesn't really want to get pregnant again, and abstinence, condoms, birth control pills, and something else are your choices, which is your correct answer? Wrong. Because there's a 16-year-old girl who already got pregnant not going to have sex again.
Right.
Well, it's probably the only thing on the boards where they're absolutely accurate with real life. It's going to be condoms. Because they're not going to take something daily. They're not going to be compliant with those kind of things. But condoms, they might actually follow. Right. But that's about the only time, and I've seen that question pop up a couple of different times on study guides and exams, and I'm pretty sure it was on my board. It's about the only time where they're actually practical with it, where abstinence, yes, is the most effective if they are going to do it. But if they're not going to do it, it doesn't help anybody. Maybe. I just took care of a kid whose dad was 17 and it was his second, so, you know. I would love to say that having a child seems to be enough of a deterrent, but in today's day and age, it doesn't really seem to. But gonorrhea is the other one that we see. If left untreated, it also is typically asymptomatic, but it will ascend and cause pelvic inflammatory disease as well. It can actually go and disseminate systemically and end up with an arthritis. They can end up with endocarditis, toxic hepatitis. This is where we start seeing like the long-term effects of it that can lead to death. There is an increased risk of pelvic inflammatory disease, infertility, kind of the same deal as with chlamydia. It is associated with pregnancy complications. We tend to see chorioamnionitis, which is an infection of the amnion layer, the amniotic sacs, basically. Preterm deliveries, postpartum endometriosis. So this is one of those, Isaiah, that you were asking about, like how it can kind of come about. And these are the situations that are kind of the abnormal, but you might see it because of the systemic disbursement of the infected tissue. Antibiotics, again, doxycycline, tetracycline, erythromycin. The big one there that you'll notice is erythromycin, because we give erythromycin to every baby that's born, and we put it ocularly. They get it because gonorrhea is asymptomatic. If gonorrhea and chlamydia are asymptomatic, and a baby delivers through a vaginal canal through a mom who says, I don't have it, I'm not symptomatic, and that baby gets it, it actually can cause what's called, I'm having a total brain fart. It's basically blindness in infants if it doesn't get treated. So prophylactically, we give ophthalmia neonatorum, and we'll talk about that later in the semester. But that's the official diagnosis of what they can end up with, and it's an infection, a gonorrheal infection in their actual eye that will cause them to be blind if it's left untreated. So every infant gets erythromycin to their eyes on delivery. Parents can refuse it. Most people don't, and we don't usually educate them on the fact that they can refuse it. It's usually just done. It's one of those, I mean, they can refuse anything. You don't educate them on everything they can refuse, but it's not typically one of the ones that people refuse. Although I have seen it. So again, we're assessing the health history for risk factors, that sort of stuff. Do you guys have any questions on chlamydia and gonorrhea? Okay. Herpes and syphilis. Herpes is a lifelong viral infection. There's no treatment for it. It is kind of seen in two different phases. There's a primary phase, so the initial infection where they end up with painful vesicular lesions. It comes out with a discharge. They have fever, chills, kind of the flu-like symptoms. Sometimes they'll have inguinal tenderness from the lymphadenopathy of it ascending and kind of taking hold. The vesicles will weep, and finally they will crust over dry, and then they disappear, and it doesn't scar. The problem is it does recur. It's kind of like chicken pox. It goes into a dormant phase and then comes back out under any conditions of stress. Typically, it's much more localized in the recurrent infection. It resolves much quicker, and they get kind of like an aura beforehand, like a tingling sensation at the exact site, an itching, a pain. People will tell you the same thing about canker sores. Canker sores are a herpes simplex virus. It's the HSV1 versus HSV2 debate, but they are a viral infection, and something they're very strict about in the NICU because you can transmit a herpes simplex virus from the mouth to an infant and cause an overwhelming sepsis and eventually a neurological devastation and death if it doesn't get treated fast enough. So it's not something benign. People are not allowed. If you guys have any observation days in the NICU, I can't remember. If you have an open cold sore, you have to wear a mask the entire time you're there, as well as gowns and gloves, typically, because the risk of transmission is so high. Antiviral drug therapy does help to reduce it or suppress it. Important thing to note, and we'll cover this more when we start looking at OB stuff, people can deliver babies vaginally if they have a history of herpes with no problem, but if they have an outbreak, it's an automatic C-section. It's one of the absolute indications for a C-section, no ifs, ands, or buts about it, because of the risk of transmission and overwhelming sepsis in the baby being passed through open lesions. If they do not have an active lesion, it's fine for them to deliver vaginally, but if they have an active outbreak, it's an automatic C-section, no holds barred. Syphilis, it is a curable bacterial infection. However, it can have some serious long-term effects if it's not treated. And it's also important to note, while herpes can be transmitted through the birth canal, syphilis is transmitted via the placenta. So if you have somebody that has syphilis, that baby can end up with overwhelming syphilis just by being carried during pregnancy. Symptoms, typically they end up with frequent abortions, prematurity, stillbirth, multi-system failure, because it's like an overwhelming sepsis that these kids end up dealing with in utero. They can end up with structural bone damage as well as significant nervous system involvement, which is a shame if you have somebody who has it and gets pregnant and it hasn't been treated, because again, it's a big IM injection, but it's just a penicillin G shot. If they have a penicillin allergy, they can administer doxycycline instead, because it is susceptible to that. Treatment-wise, it depends on the treatment doesn't deviate regardless of which stage the syphilis is in. Primary is where they actually have a canker. Secondary, the canker has usually gone away and they end up with like a flu-like malaise. Oftentimes they'll have a rash, start to develop signs of alopecia, and then it goes latent and everything goes away. All of their signs and symptoms completely go away, and the only way you'd know that they have it is they'd have a positive serology. So on a lab draw, it would come back that they were positive for syphilis. It is one of the standard labs that we draw on our antepartal patients. However, not all of our antepartal patients are textbook wonderful families that come in for prenatal care. So oftentimes, you don't necessarily know what their status is on delivery. And then tertiary is where it starts to come back, and it's now life-threatening heart disease, neurologic disease. Those are usually the two that we start to see that when it starts to kill them. That's what Al Capone died from, was the neurological manifestations of syphilis. The tests that we do, those serology tests are going to be that VDRL and RPR. Those are kind of the two big ones that we do and that we see. Education, making sure that they're abstaining if those lesions are present. You would like to think that if somebody saw a penis that had a lesion like that on it, they would stay away, but that doesn't always deter people. Washing hands with soap and water after touching any of those lesions. Avoiding extreme temperatures to the area because it makes outbreaks worse. And then using condoms with non-infected partners. Although ideally you would just say get treated, and then we wouldn't have a problem. Pelvic inflammatory disease, we have mentioned this on a couple of the slides already, and it's basically where you get an ascending infection that causes inflammation to the upper female genital tract. So we're talking about the uterus or the fallopian tubes at this point. Complications are going to be ectopic pregnancies, chronic abdominal pain, depression. You kind of get the general gist of it. Treatment is going to be broad-spectrum antibiotics. And the symptoms that we see, and these ones are important because, again, you don't necessarily see these on the OB world. You see these out in the clinic or in the ER. Lower abdominal tenderness. Adnexal tenderness, which is in kind of this region. Cervical motion tenderness, so basically anything that's going to cause the cervix to move makes it hurt. So sitting up. Think about the position that the cervix is lying down, now they're sitting up, it's moved. Intercourse. Any kind of, like a full bladder is going to push and deviate that cervix back. So anything that's going to cause any kind of cervical motion at all hurts, because everything in that region is inflamed. A fever of over 101. That's a big number. It's kind of a sticking point. You just have to know it. And then vaginal discharge. Management-wise, we're going to make sure that they maintain hydration, so we're going to start an IV, give them pain medications, heat to the abdominal area, not necessarily something that you would think about. And then putting them in a semi-Fowler's position is important because it actually promotes pelvic drainage. If you think about that kind of angle, and now that uterus is tipped enough that any kind of separation or any of that, any secretions that you might have gotten as far as discharge goes, now it has a nice easy way to come out. So we're not fighting positioning in order to eradicate that infectious material. And then education to prevent recurrence obviously is going to be important. Family planning. We started to talk about this a little bit as far as educating families regarding proper selection of contraception, using the methods appropriately, and then making sure we're administering it within a culturally sensitive framework. And that's where that whole, if you have a 16-year-old that's had sex and is pregnant and trying to find contraception, that becomes their culturally sensitive framework. You've got to work around that developmental age and the culture that they are currently living in. Considering the following when choosing a contraceptive method: effectiveness. What is the most effective form of contraception? Abstinence. When we look at safety, these are all going to be, abstinence is always going to be your number one when we look at this, except for you get to the bottom and we look at partner support or willingness and personal motivation. And that's kind of where it gets a little bit tricky in evaluating what you're working with. So understanding the pros and cons of each type and who they would apply to when you think about it in the actual application. And then cultural and religious factors influencing people's views on contraception. There's a lot of information on this slide, and I'm not going to go through all of it because you guys can read. But there are a couple things that I do want to point out, and one is this fertility awareness and rhythm method. Basal body temperature is one of the ways that people will use to assess when they're ovulating, and what they'll do is they'll take their temperature every morning before getting out of bed. Associated with ovulation will be a spike in temperature. If they get a spike in temperature and they're trying not to get pregnant, the advice then would be to abstain for 3 days, because that's the longevity of an egg. So if they ovulated, now the egg has 3 days to get fertilized before it dies. That's why they abstain for those 3 days after the spike in temperature. Does that make sense? The fail point of that is that sperm also survives 3 to 5 days in that cervical mucus, right? So if they had sex 2 days before the spike, can that sperm still find its way to the egg? Absolutely. So you can see that these are not fail-proof. Cervical mucus method, that's where they evaluate the thickness and stickiness of their mucosal discharge. And they're looking for what's called spin-barkite. Spin-barkite is the marker of that mid-cycle ovulation. And it's kind of a gross thought, but it's like a booger. And if you stuck a booger between your fingers and went like this, it recoils. That's what spin-barkite's like, for lack of a better explanation. Symptothermal method is where they combine both that basal body temperature and the cervical mucus method, but then they also add in an additional recognition of self-assessment. And so they look at this thing called Mittelschmerz, which is basically a pain that's associated with ovulation, like a twinge that they'll get on either side, depending on which one's ovulating at the time. So they'll kind of use all three of those factors together to come up with a way to know when to avoid intercourse. Or, if they're looking to get pregnant, when to time it. And then the chemical previstor test, they'll actually have them test secretions on like a pH strip, basically, and it changes color when it comes into contact with the estrogen and progesterone levels from the luteal phase. And so they'll avoid it for that week. Mechanical barriers, spermicides, condoms, diaphragms, and cervical caps. If you're unfamiliar with them, I encourage you to read through. Your textbook goes through it in good detail. IUDs is basically a T-shaped device that they insert into the uterus itself. Some of them secrete hormones, some don't. And it basically creates an irritant on the lining of the uterus to prevent it from becoming a good habitable space. So it's like disrupting the surface of the uterine lining that the estrogen and progesterone are trying to create. And that's what is preventing the pregnancy. I will tell you, in the 10 years I've done this, I've probably seen 5 kids delivered IUD in hand. It's the first thing that comes out. Every single time. Like, it's kind of one of the big FUs. Like, as they come out, like, here you go, you thought you were going to stop me. And so probably one every 2 years. I mean, so it's got a fairly good rate overall when you think about the amount of kids I've probably seen delivered, but by that same token, that's a fairly high failure rate if you don't want to get pregnant. So it's, again, kind of one of those pros and cons. The hormonal skin patch is a very similar concept to the oral contraceptives, where basically it's a patch that's worn for a week and then replaced on a different part of the body to release hormones into the system to prevent ovulation. Same thing with oral contraceptives. They're ingesting synthetic levels of estrogen and progesterone, and basically what it does is it lulls the body into thinking it's pregnant, and then they get the week of placebo pills, and it says, just kidding, you're not, and it causes the whole lining to slough without actually ovulating. Implantable contraceptives, Implanon, we have started to see this in the community a little bit more now. There is finally FDA approval, and they basically put the contraceptive silicone rod into their deltoid typically, and it provides hormonal contraception for up to 3 years. Depo is a big one that we see. Planned Parenthood uses that a fair amount, and it's given every 3 months, and it's an injection. And what it does is it alters the cervical mucus so that it becomes hostile to sperm. So now instead of being alkaline, it's more acidic, thus kind of wrecking the salvation space that the sperm finally thought it had, making its way up the canal. The nice thing about Depo is that it can be used in people that have sickle cell disease, people that are taking anticonvulsants, or people that are on rifampin, whereas oral birth control pills, they can't because of the increased risk of clots. However, they should not be used with those that are at an increased risk of osteoporosis because of the exposure and alteration in the hormonal pattern, and it has the potential to make the osteoporosis worse. So these are the pictures. You've got the female condom on the top left, the cervical cap on the top right. It's kind of this little piece right here, and it basically just blocks the entrance. You've got the condom on the bottom left, the standard male condom, and then the IUD on the right, and kind of how it goes into position. The least effective methods, coitus interruptus, which is basically where he pulls out before he finishes. There are sperm in the pre-ejaculate, so that's part of the reason why that's not as effective. Post-coital douching is where they try to rinse out everything that was in there, but unfortunately it doesn't get everything, especially if it's gotten into that cervical mucus already. And then breastfeeding. We're going to talk a ton about that later on in the semester. It works in theory because the estrogen levels are kept at such a low level in order for the prolactin to stay high enough to produce milk. However, most people don't produce enough milk to suppress that estrogen level down low enough that they're not ovulating at all, which is why people do get pregnant when they're breastfeeding. Surgical sterilization, that's that vasectomy or a tubal ligation. Informed consent absolutely must be obtained before any of that is done. And then our responsibilities when it comes to all of this kind of stuff are going to be educating them about the fact that it does not prevent STDs. It might prevent, it might prevent pregnancy, but it does not prevent STDs. Discharge education is going to be very important as far as infections, that sort of stuff goes. Any questions? Okay. Now we get into the really complicated part of the semester. Have you guys had anything on genetics yet? Nada? A little bit? Okay. So we're going to kind of go through the basics of it here. Genetics, by definition, are the master blueprint for our characteristics. They're determined by genes within each of the chromosomes, and those genes are located in the nucleus of every cell circulating through our body. It's what tells the cells how to function. It tells us why we have blue eyes or brown eyes or blonde hair or wide hips or narrow hips. It controls all of that kind of stuff. The very first cell that creates a human being is formed when a sperm and an egg join. In our systems, chromosomes occur in pairs, always. So you have 2 of each chromosome. Chromosome 1, chromosome 2, chromosome 3, all the way down to chromosome 22. All of those come in pairs. Then you have the gametes, which are what determine if somebody's a boy or a girl. And they're not necessarily paired. They might be. In a girl's situation, you have an X and an X. In a boy's situation, you have an X and a Y. The way it's determined if somebody is a boy or a girl always comes from the male. Because the mom, XX, can only give an X. Dad has the X and the Y, and he can give either or. He is the sole responsibility for determining if that child is a boy or a girl. Does that make sense? That designation is determined at conception, at fertilization. Not at the 20-week ultrasound when they get a picture and they say, oh, it's a boy. Not at birth when the kid comes out and they say, oh, it's a girl. At conception is when that is determined. Mitosis is what is the process that happens in our bodies all the time by which all of our cells produce naturally. Now, you guys should have had this in your bio course, right? So that's where you've got one cell, it's got the cleavage, it splits into 2. You've got one cell, it cleaves, it splits into 2. Now, meiosis is very different. This is going to be the type of cell division that we see that creates the reproductive cells. Because unlike every other cell in the body, the reproductive cell doesn't have 46 chromosomes. It has 23. Because if you had 2 reproductive cells that each had 46 and they combined, now you've got a cell with 92. That doesn't work. So the body has created a way by which it divides that 46 down in half to create a reproductive cell. So that when it combines with the male or female counterpart, now the 2 23s become 46. Does that make sense? So meiosis is the way that chromosomes are actually reduced by half, each with one sex chromosome in it. So again, dad gives either an X or a Y, mom gives either an X or an X. They don't give both. And then the little picture on the right-hand side kind of gives you a visual explanation of how it becomes a boy or a girl. Does that make sense? Clear as mud? Okay. So embryonic development. So now we have a sperm and we have an egg, and they meet. And we get what's called conception or fertilization. They're kind of interchangeable. Typically, or ideally, that's going to take place in that outer third of the fallopian tube. So if you look at the picture up on the screen, we've got that released egg, the released egg. Now we've got fertilization. You can see there's a whole bunch of little sperm trying to get into the egg, but only one lucky little sucker gets in there. And it creates what's called the zona pellucida, which is this zone. It's like a force field that goes out. The second one gets in, the force field goes out and blocks all the other sperm. So you can't get fertilization by more than one sperm at a time. Does that make sense? And that happens in the outer third of that fallopian tube. So it's one of 2 ways with twins. Either you have monozygotic twins, where it's one egg and one sperm, and things go awry somehow, and that one egg and one sperm, as it's multiplying, splits. Those are identical twins. The other way that it happens is you've got a female who's an overproducer, and rather than having one mature egg, you have 2 or 3. Or 4 or 5. And those all come out, and And you might have one sperm that hits one, and one that hits another, and one that hits another, and now you have triplets that are not identical. They might look similar, but they are not identical. But very important, and we're going to talk a lot more about twins as the semester goes on. So that all makes sense as far as how we get from 1 to 2? So it gets fertilized. Now it's fertilized, and it's got a new name called a zygote. And a zygote travels its way on down, and you can see it goes from 1 cell to 2 cells to 4 cells to 8 cells, and then that 8 cells transfers into 16 cells. And it's called a morula at that point. What's neat about the morula is that now becomes, as it's multiplying, it transfers into what's called a blastocyst. And this blastocyst is listed here in the picture. You've got a collection of cells that all stay up near each other, and you get a periphery of cells that go around the whole mass. And you get a little bit of fluid kind of in this space. That ring around the outside is called the trophoblast, or the trophoblastic layer. That is eventually what will create placental tissue. In the interim, it will become the yolk sac, and that eventually is what attaches itself to the lining of the uterus. During implantation, ideally, you've got this blastocyst that's traveling down, and you want it to connect in the upper third of the body, kind of in that fundal region, on the posterior wall of the uterus. Because that's got the best circulation, it's got the best blood supply, it's got the best growth potential for that fetus. That being said, if it attaches somewhere else, does that mean that it's wrong? No. It just means that it's going to have a different presentation. Anterior presentations mom doesn't tend to feel fetal movement as much because the placenta is in the front and in the way. Those kind of things. So ideally, we want to see it in that upper third. Does that all make sense to you guys? Okay. So two things that we start to see develop very early on are going to be the amniotic sac and fluid that is associated with it, and the placenta. The amniotic sac is a series of membranes that begin to form immediately upon implantation, and we get what's called the amnion and the chorion. The chorion is the outer membrane that then attaches to the maternal side of the uterus to create the maternal side of the placenta. The amnion is the inner membrane that protects the embryo, and it forms the cavity that the embryo floats in, also known as the amniotic sac. Make sense kind of where the words come from? As the fetus grows, the two amnion and chorion sides will fuse together to become that amniotic sac, the chorion being mom's side, the amnion being baby's side, and it will contain what's called a clear, sometimes straw color, yellowish color liquid. That's the amniotic fluid. It's comprised mostly of water. It will also have trace amounts of protein, glucose, urine, and vernix. Urine is, it's actually one of the ways that we know that the fetal kidneys are growing appropriately and functioning appropriately, is that the amniotic fluid volume is appropriate, because that's part of how the amniotic fluid gets created, is the baby pees it out. It is initially derived from maternal blood, but again, later it's added to by that fetal urine excretion. The placenta is the other supportive structure, and it's what permits the exchange of materials that are normally carried in the bloodstream between the mom and the baby. Mom's blood never goes to baby, and baby's blood never goes to mom. That barrier is what stays in between, and it transfers nutrients across that barrier. So you've got baby circulating, mom circulating. Okay? I will give you a bit of a deviation to that later on when we start talking about RH and whatnot next week. But the general premise is that barrier stays nice and solid. Mom's blood never mixes with baby's blood. The placenta does begin to form as that trophoblastic layer, and it will start to proliferate, and it develops these chorionic villi. They're like little cilia that actually penetrate the decidua, which is that endometrial lining of the uterus, in order to find its home. And it basically extends these little roots out and attaches to the uterine lining. That happens 17 days after conception. So theoretically, 3 days after they've missed their period, if they're regular. There's a lot that happens really early on. So it functions to protect, to provide nutrients. It provides oxygenation and carbon dioxide removal. It excretes fetal waste. We're not talking about poop. We're talking about byproducts of cellular production, electrolytes, things like that. And then it produces hormones as well. It produces progesterone and estrogen. It also produces what's called relaxin, which causes the relaxation of the tendons and ligaments in mom's hips and pelvic cavity in order to be able to allow for passage of that baby. That is a placenta. Beautiful, isn't it? It's so gross. They look like a big piece of liver. They're really cool, but they're really gross. So as we look at pregnancy, we start to look at fetal development. Now, there is a ton of information on this in your textbook, and I very much encourage you to read it, because we could spend an entire 4 hours talking about this today, and I just don't have time. So the fetus develops in a very orderly fashion, and this will also carry through when we start talking about pediatric stuff as well. They develop in what's called a cephalocaudal fashion. Cephalo meaning head, caudal meaning tail, technically, but feet. So they develop in a head-to-toe fashion. By definition, it's called a zygote from the time they're conceived until its second week. At week 2, it is now called an embryo. It's called an embryo from week 2 to week 8. And this period of time is called the organogenesis period. And it is super critical. Those first 8 weeks are when the majority of the fetal organs are developed and created. How many people do you think know definitively that they're pregnant at week 3? Yeah, most people don't. You can imagine how much can go wrong before somebody ever finds out that they're even pregnant. And that's assuming that they have good prenatal care. After the 8th week, so starting on week 9, now it's deemed a fetus. And it's deemed a fetus until it's born. You notice it doesn't say till term, it just says till born. So some of the things that we notice that are kind of key development points throughout their development. You'll notice there's probably slight deviations in these numbers. You know, it might say 3rd to 4th week in your textbook. I'm not going to necessarily need you to know the exact, at 3 weeks and 6 days, this is what happens. But you should know that in the first 3 to 4 weeks this happens, in the 7 to 9 week time frame this happens, you know, a vague idea of when these developments are occurring. Because they're important when we start to look at the things that can go wrong. So fetal development. In the 3rd week of fetal life, that baby has a neural tube, which is basically the brain and what will turn into a spinal cord, and a primitive heart. That fetus has a heart at 3 weeks of gestation, long before most people know they're pregnant. Most people don't know they're pregnant until the 4th week, which would be when they would miss their periods, basically. By the 7th week, we're now starting to see all major organs and systems that are present, and you can see a fetal heartbeat, on ultrasound. It looks like a flicker of light just doing this because it doesn't actually have 4 chambers, but you can measure a heart rate at that point. It's usually around 120 beats per minute. Pretty cool. It's usually by the 6th week that they can start to see that. It takes until about the 10th to the 12th week for them to be able to hear a heart rate on the Doppler machine, and that's where they put that ultrasound Doppler to the mom's belly, and they can actually hear the fetal heart rate. At the 10th week, if they're not hearing it, it's not a bad sign. Sometimes it just takes a little bit longer depending on where the baby is positioned, but by the 12th week, they really should be able to hear it. By the 14th week, the fetus will actually move in response to stimuli. That doesn't mean that mom can feel it, but you can see it on the ultrasound. You know, they'll put the ultrasound machine on, and mom will drink a glass of water, and that baby will just, run from the cold. Because the second that cold water hits the stomach, the fetus tries to kind of get away. It's pretty cool. When you get to see this stuff on ultrasound. By the 17th week, typically the sex of the fetus is visible, so they can usually tell if it's a boy or a girl by then. Although they don't usually guarantee their findings. A key note is that the age of viability is between 22 and 23 weeks. Age of viability means the age at which we can do things resuscitatively in order to enable that child to survive. Beyond that, before that, they're too underdeveloped. And at 22 to 23 weeks, the odds of survival are still fairly small. And a lot of it boils down to the size of equipment. Babies much under 500 grams, which is the equivalent of about a pound, we don't have sufficient equipment to really support their airways, or machines that are gentle enough to not cause their airways to end up with a pneumothorax or a pulmonary hemorrhage, or supporting their gut development. There's just a lot to it that we don't have the capabilities of yet. By the 28th week, and this is a big one, production of surfactant starts. Surfactant is something that we all have in our lungs. Surfactant, you'll notice, is on soap bottles. They'll talk about surfactant present when they talk about dish soap. And what they're using is basically the same kind of material that's inside all of our lungs, and our beta-2 cells secrete it within the lung tissue itself. And what it does, very much like at the end of the day in nursing school when you're totally exhausted and you get home and you cook a cheese pizza from DiGiorno and you stick it in the oven, and all the cheese is melty and gray and it sticks to the pan, right? And you get it out and you eat your pizza and you're just beat down tired because you've been in lecture for 4 hours and you've been studying for 8 and you can't see straight, and you kind of forget that that pan is just sitting on the counter, right? How many people do their dishes right away? I am not one of them, still, to this day. So the next morning you wake up and you go to wash that pan. How awful is it trying to get that cheese off the pan? It's terrible, right? You're sitting there like scraping the cheese and hoping that you're not completely destroying the nonstick surface. And that's what life is like for a 24-week baby trying to breathe. Every breath is like trying to pry that cheese off of that pan because they don't have surfactant. You put soap on that pan and you let it sit for a little while. And you go to get that cheese off. How much easier is it? It still probably doesn't just like slide right off, but it comes off a whole lot easier. Same premise when it comes to surfactant. We can actually administer surfactant now, and we couldn't 15 years ago, 20 years ago. So we can administer surfactant to help these 27-weekers, 24-weekers, 28-weekers that don't have quite enough. And what it does is, in between every single breath, now their lungs slide apart, rather than trying to pry that burnt cheese off every single time. So surfactant production very much dictates and delineates a lot of viability for us. 20 years ago, they couldn't save anything under 28 weeks because every single breath was damaging that lung tissue, and now they can. 39 to 40 weeks is by definition term. For a while, they were doing C-sections and inductions at 36 weeks because those kids were near term. And insurance companies were the only way we got a kibosh put on that, because what they were finding is that those kids weren't ready to be out of the oven yet. And they were ending up in the NICU with a whole host of complications because they weren't ready. Some 36-weekers might be fine, and moms that go into labor at 36 weeks might be fine, but they might not. And so those kids are very much the kind of kids that you guys need to keep an eye for, and it should be a little bit of a flag that says that kid's not term. They don't necessarily need the NICU, but they need closer observation. I need to make sure I keep my eyes on that kid because you don't trust them because they're not term. Term, by definition, is 39 to 40 weeks. 42 plus weeks is deemed post-mature, and they give it that 2-week window because of the variability in people knowing exactly when they ovulated. In kids that are post-mature, you see longer nails. They tend to have more hair and less fat, because that placenta has started to deteriorate, and so now they're not getting the nutritional supply that they need from mom over those 2 weeks. So delivering post-mature is not benign either, because those kids have actually started to waste and they're chewing through their fat stores trying to stay alive, basically, in utero. They tend to have very dry and peeling skin because the amount of amniotic fluid tends to go down a little bit as well. But they do have long nails and hair because none of that stops growing. So they end up with like claws on their fingernails. I mean, it's kind of impressive when you see a kid, and you know it. I mean, after doing this for 10 years, I can look at a kid and tell you that kid's not 40 weeks, that kid's 40, it's well beyond. Because their skin's literally peeling off. You go to do handprints and footprints, and there's like pieces of skin on the ink pad.
My daughter did that. She was like,
Yep.
she peeled for like 3 weeks after she was born.
But you do. Once you see a true post-date child, you know exactly. I mean, you never forget what they look like. So this kind of is a picture just to give you an idea of what it looks like. At 8 weeks, it's pretty alien-esque. At 6 weeks, if you ever see an ultrasound of a baby that early, it looks like a seahorse. Like it's got a tail even that eventually, you know, you can kind of see it a little bit here. You know, it sort of starts to normalize, but I mean, at 18 weeks, you've got a pretty well developed what looks like baby sucking on its thumb. You know, it doesn't take long to look like a human baby. It's pretty cool. Effects of teratogens on fetal development. Teratogens are basically anything that can be harmful to the developing fetus. Medication, substances, radiation exposure, whatever it may be. And so really what we advise is that people take as little medication during pregnancy as possible. There are a lot of substances that can cross the placenta and cause major fetal abnormalities. And really the susceptibility to damage depends on the period of development. There are certain periods of time that certain organ systems are much more vulnerable. And it just sort of depends. In those first 8 weeks, it's one of the reasons why, as a big health promotion push, everything has folic acid in it now, right? You hear about it all the time. It's in bread, it's in cereal, it's in every carbohydrate you could possibly think of. Because neural tube defects, open neural tube defects, so kids that have spina bifida, that development happens in those first 8 weeks, long before most people know they're pregnant. So they started adding things like folic acid into foods that the general population eats so that those levels will be higher to prevent those defects in the people that don't know that they're pregnant. Because there's not necessarily something that any of us can do unless people are adamantly trying and restricting everything that they're doing as if they were pregnant to protect a growing fetus in those first 8 weeks. So during that first trimester, the first 12 to 15 weeks, the fetus is the most vulnerable to the effects of medication. So we always want to make sure that we're verifying the date of their last menstrual period before we ever make recommendations about meds at all. Circulation changes. Now this one is a big one, and it can get to be very complicated. This is that slide that was in there as like a supplemental for you guys. That's for you, especially for those of you guys that are visual learners. I found that it's very helpful to go through. There's a slide on here, on our next slide, that talks about and shows you the colors and everything of what fetal circulation should look like compared to neonatal circulation, which is basically adult, normal human being circulation. That blank one is there for you guys to use. I encourage you, take colored pencils. When you go to study this, study the slides, make it make sense. Have that next to you and color it, red and blue and purple, according to where the blood flow is going so that it makes sense. Don't try to memorize this stuff. It will come back to haunt you, I promise, when we go to do peds. Because there's a whole bunch of cardiac stuff that can go awry that we will talk about then. So, circulation changes. With fetal circulation, after the 4th week of gestation, the placental blood circulation is very well established. So now basically the fetus has its own blood circulation starting at the 4th week. Because the fetus doesn't breathe and the liver does not process things very well in the fetal period, most of the waste products and physiologic diversions are needed because the body is not going to waste energy pumping blood to a system that isn't functional. So a little bit of blood will go to the lungs and a little bit of blood will go to the liver to help them develop, but that's about it because the body's not going to waste time shunting all of that blood through lungs that aren't giving it oxygen. It's not going to shunt a whole bunch of blood through the liver that's not clearing any waste products. So fetal circulation has 3 shunts in it, and I'll talk about these here in just a second when we've got the picture, but we've got the ductus venosus, And this is the one that shunts blood away from the liver on its way back to the placenta, because the placenta is going to be what does most of that filtration. The foramen ovale, which is a hole that is between the right atrium and the left atrium. And what happens is most of the blood is going to get pumped directly across that hole rather than going into the left atrium and out to the lungs. The ductus arteriosus, however, diverts most blood going from the pulmonary artery directly to the aorta, again, shunting blood away from the lungs because they don't need it. After birth, those fetal shunts aren't needed. So once that baby takes that initial breath and changes the pressures of oxygen and CO2 inside their system, blood shifts in its circulation, and blood's going to the lungs now. That initial breath is imperative in order to make that all happen. The ductus venosus gets closed when we put that cord clamp on, because now there's no blood going through it. The foramen ovale is going to close because of a pressure shift as that blood flow decides to now start going to the lungs. Typically, it's functionally closed within 2 hours of birth. And we say functionally because if things go awry, it can open back up again. It's not structurally closed for up to like a week or two. And then the ductus arteriosus, as those blood oxygen levels increase, oxygenation actually causes vasoconstriction, and it vasoconstricts that ductus arteriosus to close it. And typically that happens in about 15 hours after birth, but some kids can take up to 2 to 3 days. It just sort of depends. So, I'm sure all of this is completely foreign, and you guys are all staring at me like, what the heck are we talking about? But this is neonatal circulation, so this is adult normal. You guys should be familiar with this adult function. This is what we expect to see within 2 to 3 days of birth. Really, we expect to see this within a couple of hours of birth. Okay? When we look at fetal circulation, things are a little bit differently. And if you look at the colors, that should be kind of your number one sign to start with. So, coming from the placenta, very counterintuitive to what you see in adult functioning, we've got 2 arteries and 1 vein. The vein is bringing the blood from the baby back to the mom, and the arteries are bringing it to baby. So you've got, sorry, I just looked at it. The umbilical arteries are going away from the baby to mom. The umbilical vein is coming from mom to baby. If you remember it, arteries start with A. A means away. That's usually how I do it. But. So you've got the umbilical vein coming from mom. You've got it going up into the inferior vena cava, into the right ventricle, or the right atrium, excuse me, right? Just like it would normally, the inferior vena cava into the right atrium, except it's oxygenated blood now, right? Because it's coming from mom. It's going to go into the right atrium, into the, am I backwards? Yeah, there we go. I'm like, wait a minute, I'm looking at, it's hard doing this number, trying to turn around and read it. So you've got the right atrium, and normally it would go from the right atrium, because it would be blue blood. It would go down to the right ventricle, up to the pulmonary arteries, to the lungs, right? But we don't need it to go to the lungs. So a little bit will come down this way and come to the lungs, just enough to get them to grow and to thrive. The majority of that blood is going to shunt right across what's called the foramen ovale. And that foramen ovale is a nice big old hole, and it shunts straight across into the left atrium, down into the left ventricle, just like it would normally, and it's still red blood, just like it had been, and it's going to go up the aorta and down out to the body. Does that make sense so far? Except for we can't forget about the blood that was going up those pulmonary arteries to those lungs. We want to give that diversion in case too much has gone that way. And that's where that ductus arteriosus comes. So you've got this nice red blood that's coming from mom, and as it's hitting this right atrium, it's also getting the blood return coming from the rest of baby's system, which is blue, right? Just like it would be here. Coming from the superior vena cava, coming back to the heart. Once it's here, it's blue, and it's mixing with that red as it's shooting down into that right ventricle, so now it's purple. Going to those lungs, it's purple, it meets with that red blood coming out of the aorta, and it's purple going to baby. That's why when babies are born, purple. Baby stacks on delivery are somewhere between 50 and 60% on average because of this.
So arteries are moved from mom or baby?
Baby. Yep, away from baby, same thing here. Like their heart is here, pulmonary arteries go away from the heart.
And the veins are towards
baby. Inferior and superior vena cava come towards the heart, towards baby. Does that make sense?
So they're purple because it's not as oxygenated as it would be going to.
It's purple because you get the nice red blood coming from mom, and the blue blood, like you normally would be, coming from the rest of baby's circulating body, and they're mixing. Red, blue, purple. Make sense? Make sense?
Yeah.
Makes sense until you leave here, which is why I gave you that colored drawing to sit there and color until it makes sense. Print out 12 copies and that. That was the easiest way for me to like make it stick. Because honestly, this is great, and it's great you get it here, but the second you leave this room, and that'll be that. So use that color. I promise it'll help. It'll help make it stick a little bit more anyway. So, now we have exactly what is going on in utero up until the point of delivery, right? But how do we know that somebody's pregnant? How do we know that that's what's going on inside? There's 3 different categories for the signs of pregnancy, and you have to know the differences between each. We have presumptive signs. These are signs where people assume they're pregnant. Right? They're things that would lead somebody to believe they would be pregnant. These are the least reliable. They're subjective. What we see, these symptoms we start to see because there's this rise in hormone levels that are a result of the implantation of that trophoblast. It's the HCG levels that we are testing for, that trophoblast is releasing, that tells us there's a pregnancy there, that are causing these symptoms. Nausea and vomiting. That's one of the #1 signs that causes people to say, I might be pregnant. What else could cause somebody to be nauseous and puke? How a hangover. Or the flu. Or they ate something at Taco Treat. There's 1,000,001 different reasons why somebody could be nauseous and vomiting. How about they're really tired? How many of you are really tired? I'm going to guess Isaiah's not pregnant. Just a thought, but it's a presumptive sign of pregnancy. So you can see why these are pretty unreliable. Peeing a whole bunch. How many of you, I know you've had a cup of coffee. How many times would you anticipate being up to go pee if you've had 3 cups of coffee? Well, there you go. Maybe you've got 2 of these signs. Maybe you're pregnant. You can see why, again, these are the least reliable. If they're not having their period, well, we already covered a whole host of other reasons why somebody might not. If they're obese or they have diabetes. Breast enlargement and tenderness. Well, we talked about all those fibrocystic breast changes, right? Quickening. Fetal movement felt by the mother, that's important, that mom is the one feeling it, after about 18 to 20 weeks. They describe fetal movement as like a fluttering or like you can just feel things internally moving, right? What else could cause that sensation? Gas. So if you've got a fart, you've had a ton of caffeine, you ate a taco treat, and you're in nursing school, you might be pregnant. Those are your presumptive signs. Make sense? Probable signs are more objective. They're things that are harder to define away as something else. So we've got Goodell's sign, which is a softening of the cervix. So if you think about kind of the consistency of like a down pillow versus a memory foam pillow, that's Goodell's sign. Memory foam would be normal. Down pillow would be more like Goodell-Stein. It's softening. And it has to do with, again, that estrogen and progesterone relaxin being released by that trophoblast. Chadwick-Stein is on vaginal inspection. It has kind of a bluish or a purple hue, and it has to do with the blood flow and blood supply to that cervix. Hagar-Stein is a softening of the lower uterine segment. So basically, again, due to that relaxin, those muscles are kind of relaxing like they should. Ballottement is where the fetus floats away from the cervix when it's pushed on. So basically, somebody is manually, internally pushing on the cervix, and you can feel that what's inside is moving away from it. That could also happen by if there's a tumor in there, if there's a uterine fibroid in there. It'll have very much the same presentation. A positive pregnancy test. That's a probable sign. What do they tell you on those little pamphlets that come in the home pregnancy test to do when it comes back positive? See your healthcare provider, because there are other things that can cause a positive pregnancy test. There are deviations, there's abnormalities, there are things like molar pregnancies, hydatidiform mole, things like that will secrete HCG that will give a positive pregnancy test, but they are not pregnant. Probably. The only signs that are positive, absolute signs of pregnancy that are signs because they are attributable only to the fetus requires the confirmation by an experienced healthcare provider. So things like fetal heart rate. Nothing else is going to create a heart rate in there except a fetus. Fetal movement felt by an experienced practitioner. Now we're talking about actually having your hands on mom's belly and feeling it move. Again, it's got to be an experienced practitioner that's doing this, assessing it to make sure that it's an accurate assessment. And then ultrasound. Ultrasound is the only number one, 100% definitive way to know that somebody is pregnant, because when they do an ultrasound and they see a baby in there, there's a baby in there. Sound fair? And that's the end. We even finished 4 minutes early, guys. I'm kind of impressed. Do you guys have any questions? Do you need me to go over the fetal circulation again? Yes. Yes? Okay. Yes?
Did you look over the non-colored picture that we It looks different.
It does look different. And if you, the only problem, I was going to do one of these ones, but I can't get the color off of them. But Carol. So if you look at the one that's in the picture, you got the placenta down here, right? And that correlates to your little squiggly lines down here. Okay? This one coming out of the placenta is your umbilical vein. That's here. And this one down here are the umbilical arteries. This gobbledygook mass is the liver.
Yeah.
Does that make sense? Is that where the confusion was? Okay. Liver. Artery. Okay. Yep. Okay. So, are you guys comfortable with regular, normal human being circulation? Okay. So, we've got blood that comes from mom, and this is going through the umbilical. That's red. Good so far? That umbilical vein is going to bypass, we're going to go by, kind of just like steer clear of the liver, and it's going to go up into the right ventricle. That's where your first abnormality is, right? Because in here we don't have entrance into that right ventricle. That's why this right ventricle is red.
What is it, the atrium?
Or, sorry, right atrium. Okay. Thank you. Right atrium is red, whereas here is blue. The majority of that blood is going to shoot across through this opening here, through the foraminal valley, which doesn't exist here. You can see it's actually this little flap right there is what that becomes. So it shoots across that foraminal valley into the left atrium. It goes down into the left ventricle, and you can see the little arrow is still red. And it's going to go up into the aortic branch, just like it does here. Red, red, up into the aortic branch. Okay? Still good? We're going to halt there for a second. We're going to come back over to the right atrium. So the blood's come in here. Now, some of it is going to trickle down into the right ventricle. Now, that blood that's heading south into that right ventricle is mixed, because in normal functioning, you've got blue blood coming from the superior and the inferior vena cava into this right atrium, making it blue, right? And we have the same thing in the baby. Okay? So it's coming into that same right ventricle and heading south, because that's where its pressure is pushing it, along with that little trickle of red blood that's coming from the placental, the umbilical vein into that right atrium, mixing with the blue blood coming from that superior vena cava, going into that right ventricle, and now we're purple. Because we've got blue mixing with that little bit of red, making purple. That purple blood now is going to go to the lungs, just like it normally would have when it was blue, right? It's purple, but we don't need all of that blood to go to the lungs, right? We don't need to overload them because they don't function. It's not going to get red by going to the lungs, so there's no point. So just enough goes to the lungs to make sure that they grow. And the rest of it bypasses across what's called this ductus arteriosus. And it joins the aortic branch where we had paused before with the red blood. Red blood plus purple blood is still pretty purple blood. And it goes out to the rest of the baby's body. One thing you will notice is in this arch, these top three stay nice and red, right? What do these feed? The brain. What's the most important part of the body for that baby to grow and develop? The brain. It gets the best blood. The rest of the body gets what it gets, and it's fine. It'll grow. But the brain needs the best part.
Which part is it the valley that is open and physicians sometimes have to tell the parents, and then the parents freak out because the children have a hole in the heart?
Yep.
Okay. Is that more common than?
Yeah, I mean, it's not uncommon by any means. They're usually pretty benign, especially if they're small. Sometimes kids will grow out of them. A lot of times what happens is this flap doesn't stay closed effectively, and so with changes in fluid volume or temperature, it'll kind of fluctuate open and close. And if it's substantially large, yeah, they'll have to get it corrected. Yep.
So could you go back to the blood? So once we were coming down, you know, we went through the aorta, and it was going to be the extremity. What stage does it go back to mom for more oxygen?
Gotcha. Good question. So it goes back out to baby's extremities just like it normally would. And as all of that venous return were to come back to go to the heart, it goes out.
Side down to the
Yep. Yep. Yep.
Thank you.
Yeah. Thank you. Yeah. I'm glad you guys asked. Thank you. My pleasure. So, is it as scary? Yep. And they are online.
And the quiz as well, right?
Yes. So the quiz before midnight of Wednesday night beforehand, and the ACI journals next week. The quiz. The quiz is open book. It is not teamwork. If you guys are found to be doing it together, it will be a 0 for everybody. So.
And then in ATI for a journal, is there an aid for your class? Do you take like which stuff? Yeah.
I honestly have no idea.
Well, it's an AR,
Honestly, the questions don't matter to me. It's for you guys. It's for your practice and getting comfortable. And so.
Just follow the rubric.
Yep, it's exactly the same as it was for Mrs. Hastings.
Okay. Thank you.
Yeah.
Oh yeah, Lexi. Yeah.